We are live.
Good morning. Welcome to the inaugural session of Guru Sangam, which is a unique initiative by the President of AIOS, Dr. Harbanslal, to empower teachers with the aim of education, elevation, and excellence. So this is the inaugural session, and each of such sessions over the next 10 weeks will feature various teachers in ophthalmology presenting best of their lectures. And at the end of it, we plan to have a conclave of ophthalmology teachers. I welcome the president of AIOS, Dr. Harbanslal, to say a few words, since it's been his idea and his perseverance that led to this unique program.
So, good morning, Santosh, and good morning, friends. I have traveled across the country and particularly in North India, and I found the education standards actually varies a lot. And some of the places there's no teaching whatsoever, and people pass out completing their MS with no knowledge of even doing the gonioscopy, slit lamp examination, and the basic things, and forget about the surgery. And so I thought, and there may be some of the keen teachers who are keen in teaching, but maybe because of the system is such that they are not able to educate the people over there. So we thought we will encourage the teachers across the country and to come forward and be a good teacher. So this platform was created with that in mind, that all those who are keen on teaching will come on this platform, and slowly students will learn from it. At the same time, we will select normally 10 of them every year, because this is a little shortened tenure of mine, because I reduced my tenure by 3 months. 10 of the teachers will be given the certificate as resource teachers, and all those who get this resource teacher award for 3 times will be given a Dronacharya award. And the students, those who attend the classes regularly, will be given the Arjuna award. And then we will have the physical meeting of all those who participated, whether they are the resource teacher or not, but they have shown interest in participation and teaching. So we plan to have 100 lectures every year. This year it will be shortened. And then we will have a physical meeting fully sponsored by the AIOS. So I welcome you all for sharing your experience and trying to teach, and let's have the young ophthalmologists who come out are the good students and the good ophthalmologists. Thereby, our patient care is really excellent, and wherever they go, they make us proud. So with these words, I'll ask you to start the program.
And thank you. I welcome Tinku Bali, who is the member of ARC Northern Zone, and she's going to be the moderator all through Guru Sangam to take on from here and conduct the program.
Thank you, sir. Thank you for having me here. I'll just share my screen. So our first speaker is Dr. Bhavna Sharma, who is a professor and head of ophthalmology and the dean of examinations at the AIMS Bhopal. Just give me a minute to share my slides. Slides are not. Okay, so, well, they say that teaching is not just giving someone facts, it's acquiring an understanding of the subjects. And I'm sure all these stellar teachers are going to give us a great understanding of the subjects that they're going to cover. So our first speaker, Dr. Bhavna Sharma, is going to be speaking on corneal topography. Let's see the curves. By way of introduction, she's a professor of ophthalmology and heading the Department of Ophthalmology at the prestigious All India Institute of Medical Sciences, Bhopal, with over 22 years of experience in clinical, academic, administrative, and the research domains. She has been a senior faculty for teaching and training of undergraduate and postgraduate students, and has a broad knowledge in leadership, collaborative research, involving basic science, and and she's been a part of teams who are engaged in research in ophthalmology. She's a recognized expert in the field of corneal and ocular surface disease with a lot of publication. Her areas of interest include corneal dystrophies and corneal transplantation, She has a degree in ophthalmology from the Regional Institute of Ophthalmology, Gandhi Medical College, Bhopal. Then she went on to do a subspecialty fellowship in cornea and cataract from the RP Center, and presently working as professor and head of ophthalmology and dean of examinations at AIMS Bhopal. So over to you, Dr. Bhavna Sharma, and we look forward to your talk on corneal topography. Let's see the curves. Dr. Bhavna, I invite you to share your screen, please.
Yes, thank you for this kind introduction. And I thank the AIOS, Dr. Sahar Banslal and Dr. Santosh Onava for giving me this opportunity to be present on this prestigious forum here. And today I'll be speaking on the corneal topography. And this is one of the most important topic which is covered not only in theory, but also is very frequently asked in viva and practical examinations. So I would be covering corneal topography, its interpretation, the functions, and the principles of doing corneal topography. I hope that my screen is visible and I'm audible.
No, perfect.
Yes.
Yes.
So the simplest analogy which I can establish for the corneal topography is our planet Earth, which has got multiple references of above the sea level and below the sea level, that is in the form of mountains and the plains. So here the curves are beautiful, but they may not be beautiful always. So whenever they're concerning the cornea, we must be suspicious of some disease process going there. With this introduction, how to examine the corneal curvature or the corneal curves, we have two basic machines. We have the basic machine, that is the corneal topography. Here it is limited by that it cannot evaluate the posterior surface of the cornea or the posterior float of the cornea, which is because of this limitation and this lacunae, the another machine or the another principle came into being, that is the corneal tomography, which supplements the reflection-based assessment of curvature with a Schimflug-based tomography assessment. And it can also measure the posterior float and also around 10 millimeter of the cornea, which was not there in the topography machine. But we know that we have been using this very humble machine of photokeratoscope and the video keratography for qualitative reflection-based corneal irregularity. Here, the principle is that these rings are projected onto the cornea to know whether about the spacing and also whether there's any irregularity in these projected rings. So that gives us a very vague information of the anterior curvature. What about the Schimflug-based tomography? So the Schimflug-based tomography is a more advanced feature. It can give you a three-dimensional model of the anterior segment of the eye that involves not only the cornea, but the complete anterior segment up to the lens iris diaphragm. And this can generate a picture from 25,000 true elevation points in less than 2 seconds. And also, as I said, it can feature the anterior and posterior floats both. There are three machines which are there. That is the Galili-based, which has the Pellicidor disc with the dual Schimflug, and the Pentacam, which has got a single Schimflug, and the Ceres machine. So we know now that it is a non-invasive imaging technique. It can measure the corneal curvature. It can measure the elevation both at the anterior and posterior float. It can measure the corneal thickness or the corneal pachymetry and all the deviations associated with this for a meaningful diagnosis and a meaningful treatment. The major clinical applications lie in identification of the cases of corneal ectasia, their diagnosis, their follow-up, and also the treatment of these cases. We screen patients for refractive surgery and also evaluating its results and follow-up of such patients, management of astigmatism in cataract surgery and a guided suture removal in such cases in patients who are having astigmatism at one point or many or other points, then planning cataract surgery and intraocular lenses, particularly for toric IOLs, and very important, the fit of contact lenses. So let's start here that in this presentation, the learning objective would be, I would take you through the principle of Schimflug camera, the functions, the interpretation, and a step-by-step approach to make a diagnosis of a patient of any disorder of corneal curvature. So here, this is what is the principle of the Schimflug camera is that if I can establish this most simple picture here, that with a simple camera, the most basic camera which we all have, if you see the point of object, the interest of object, You are focusing on that interest of object, so you would be able to visualize that central part only, whereas the rest of the surrounding objects would be more or less out of focus. So that is the main limitation here. It is because that the subject plane, the lens plane, and the image plane are all lying parallel to each other. So this gives a limited depth of focus. Now compare it with the Scheimpflug camera. This is the same picture which has been taken with the Scheimpflug camera, and you can very clearly see that not only the point of the interest of object of interest is very well seen, but also the surrounding object, and this is because we have an enhanced depth of focus. Now, what is the difference between the two? Now, the difference is that earlier the three were not in were parallel to each other, so it was a limited depth of focus. But here in the Scheimpflug, the image plane, the lens plane, and the subject plane, they are intersecting at one point, and this is the point of maximum focus. So that is how we can differentiate between a simple and the Scheimpflug based photography. So making it more clear, the Scheimpflug based camera has got a central camera which focuses on the pupil, its size, fixation, and orientation. Whereas we have another camera which rotates around 180 degrees to take the pictures at these multiple points through the cornea and through 180 degree of each curvature. So you can see this movement of the camera through 180 degrees on one side and on the other side as well. So this will generate these pictures in a 3-dimension with a slit-based photography and the Scheimpflug camera to give you a 3-dimensional picture of the anterior segment. The second point, what are the functions of the Scheimpflug camera? So it can measure the pachymetry, it can very effectively see the topography, it can do the lens densitometry and also the anterior chamber analysis. But before doing a pentacam, before doing a Scheimpflug based photography, you have to ensure all these points so that the image which you capture is meaningful and it is not missing on any data to give you a false interpretation. So the patient should have been discontinued on contact lens for at least a week to prevent contact lens related warpage. You should perform the examination before any contact testing like applanation or immersion technique and before instilling any drops. You must test the patient before dilatation, preferably in a mesopic pupil. Otherwise, dilated pupil may give an erroneous false reading because the angle kappa may change. Also, you should ensure that there is good exposure to cornea, particularly in patients with small eyes, in deep set eyes with a large nasal bridge and long lashes. They should not interfere with the image capture of the machine. And also make sure that your scale and color bars remain constant for every patient. This is why the interpretation which you'll do for each patient would also have the similar outcome. So this has to be ruled out. All the corneal surface disorders like the corneal opacity, dry eye disease, corneal warpage, all have to be ruled out to have a good capture of the image through the Scheimpflug based device. And also you must know about the concept of angle kappa. That means the angle kappa is the angle between the line of sight and the center of the pupil. So it should be that the line of sight should be aligned straight along the corneal apex and the center of the pupil. Any deviation or a large angle kappa may result in a false report of steepening even when there's no such abnormality which is existing. So with this background of knowledge, let us go to the interpretation. When you see a map which is being brought in front of you for the diagnosis, you have to see the patient you have to see the map in these subsections. To start with, the first upper left-hand corner gives us the patient details. Now, this is very important, the patient details, because in the subsequent slides, you will come to know that it is the age and gender match controls standard deviation, which is also considered while considering this map. The second is the cornea front. The next is the cornea back, the pachymetric indices, and the anterior chamber indices. Then we move on to the right side of this map. The first is the sagittal curvature or axial map. The second is the elevation front, the elevation back, and the corneal thickness profile. So this is the composite map which you have on the first page. On the second page, you have got the corneal thickness spatial profile. It gives you the thickness profile in relation to the location, and also towards the left-hand side, you can see these irregularity indices, which you don't want to memorize. It is nothing to memorize. The computer itself will tell you if there are red readings, it is a straight case of an abnormality. If this is yellow, then it is suspicious. The keratoconus index would be given by the machine, the corneal volume, and also the progression index, which should not be more than 1.2. The third thing which the machine gives us is the bad display or Bellin-Ambrosio enhanced display. So with this, you can see these three maps, that is the elevation maps of the anterior and posterior curvature, the exclusion map, and the difference map. Right. So we take one by one all of these, which I just informed. So the first thing is the cornea front. So cornea front and the cornea back, you must ensure that this quality specification should always be written here as okay or white. If it is yellow, that means the machine is missing some data and you want to recapture the image. If it is red, then you definitely want to recapture for a meaningful interpretation. The Q value should lie, it is about the shape of the cornea or the asphericity of the cornea. So you want to know this because the patient may be a myopic or a hypermetropic. So for interpretation, you want to know the asphericity. The normal value lies between 0 and -1. Any abnormality in that is, if it is more towards minus, it is a prolate cornea. If it is more towards the plus, it is a oblate cornea. So your refractive surgery procedure, your interpretation would depend on this Q value. Then the cornea front, other indices are the radius of curvature and its corresponding inverse, that is the dioptric power of the cornea on both the horizontal and the vertical meridian. The mean of keratometric value and the astigmatism it is present. The same is represented for the cornea front and the cornea back. It will give you an idea whether the keratometric value is more to cause suspicion that if this patient maybe has an abnormal area of steepening. Okay, so the next subsection is the coordinates of the corneal thickness. So the coordinates of the corneal thickness should be measured in the pupil center, the pachy apex, that is the apex of the cornea, and the thinnest location over the cornea. The X and Y coordinates are also important, particularly for the displacement of the thinnest location. Now, displacement of the thinnest location should not be more than 500 micron and 1000 micron, that is 1 millimeter from in the Y coordinate or in the vertical hemisphere. Why? Because it tells you that the cone or the steepening is deviated inferiorly. So that is very suspicious of an atectic disease. This about the cornea volume and the anterior chamber indices are important because cornea volume is now linked to the, in research, a project has been linked to the development of keratoconus. So this value should not be less than 50 millimeters. The chamber volume should not be less than 100. Similarly, the AC depth, it should not be less than 2.8. If it is so, you may not be able to put a phakic IOL in such patients. The keratometric progressive index and also angle, pupillary diameter, as I said, should be mesopic pupil where you want to do a imaging of this patient. Now, from here, we move on to the 4-map composite report. That is the sagittal curvature, the elevation front and back, the pachymetric map, and the bad display. I'll take them one by one in the subsequent slide. So this portion I have already covered. We move on to the right side. What is the sagittal curvature, the anterior elevation, the posterior, and the pachymetric map and its interpretation? So first, we take the curvature map. So this is the most simple of the map, the curvature map. It tells you about the refractive power at all selected points of the cornea. It is given as a color-coded map with all the color scale besides this map. So you can see that there are cold colors and the warm colors or hot colors. So any area of steepening would be displayed in hot colors, whereas the flattening would be displayed in cold colors. So you want to consider this importantly in the 4 and 6 millimeter zone of the cornea. So the curvature map, again, what should you see? What are the abnormalities? So the steep K rating, that is the K max, should not be more than 47 at any of the point of the cornea. The inferior superior asymmetry in this 4 millimeter zone should not be more than 1.5. That means you identify 1 point above this in the upper zone of the 4 millimeter area and the lower part of this 4 millimeter. These points should be corresponding, and the inferior asymmetry should not be more than 1.5. Then the SIM-K is the K value, which is the corneal the corneal astigmatism in difference to the total or the manifest astigmatism. It should not be 1.5 and should not be more than 15 degrees. And all of this are displayed in the machine. So this is the very representative of with the rule astigmatism. You can see that the corneal steepening is present in a symmetrical bow tie pattern. This indicates a symmetrical bow tie in the horizontal meridian, that is against the rule. The third is an irregular astigmatism or skewing of this steepest meridian. So this skewing is important. It should not be more than 22 degrees. If it is showing a skewing of more than 22 degrees, it indicates that the patient has an irregular astigmatism. Now, this is what we are concerned about. You can see an area of steepening here in the inferior part, and this indicates a cone or a inferior steepening or a thinning, which should be very carefully evaluated. Again, two pictures, which are the clinical scenario, the clinical pictures, which are seen in pellucid marginal degeneration, which is the crab claw appearance, and an isolated island with extreme areas of steepening here in cases of keratoconus. So these are other forms which can be seen in when you evaluate a patient, when you evaluate a curvature map or the axial map. So about the regular shape, the irregular shape, and the skewing of the axis, which you want to see. A word about enantiomorphism. When you are evaluating an axial curvature, always look for enantiomorphism. That is the mirror image of the anterior sagittal curvature map of one eye should be the mirror image of the other eye. That means all the points and all the elevations, the refractive powers are corresponding to each eye. There's no significant inter-eye asymmetry. The second map is which I would like to take is the elevation map. Again, the simplest analogy which can be established here is relation to the Earth. So when considering elevation in relation to the planet, you want to have a reference surface. So the reference surface here is the sea level, and any elevation or depression beneath the sea level is demarcated. Whereas in the cornea, the machine designs its own reference surface, taking into consideration all the points, all the refractive power of points, and then collating them into a single data to prepare a reference surface. So this is the reference surface which the machine has designed for this patient. All the points above this are demarcated as elevation. Points below this in height are demarcated as flattening. And this is the color-coded map of the same patient, which shows a hourglass pattern, which is normal. So the elevation map is also color-coded. You can see elevation above the surface and below the surface. So what to look for in the elevation? So the best fit sphere informs us that at any point of the cornea, the best fit sphere of 8 millimeter, you should not have an anterior surface elevation more than 15 microns and more than 20 microns in the posterior surface. The back-front difference hence should not be 5 micron at the same point. Considering the best is toric ellipsoid in the 4 millimeter zone, it should not be 12 microns more in anterior surface and more than 15 microns in posterior surface. If it is present, that is more than 12 or 15 microns, it indicates any abnormality. You want to evaluate the patient more carefully, and also look for any isolated islands on either surface, anterior and posterior. So again, a very representative picture of a normal anterior elevation. You can see all the points are within normal limits. It doesn't show any significant elevation. Again, here you can see a hourglass pattern and all the points are within normal limit. Now look here, you can see a point of elevation, very significant elevations at this inferior point to the extent of 43 and much steeper than this. There's the profound steepening here. And similarly, the corresponding area, that is the back surface elevation, is also seen. So this is a very, very suspicious case of a steepened cornea. These are two pictures to give you a comparison between a normal and an abnormal. So this is normal. You can see all the anterior points and the anterior elevation are within normal limit, whereas this is an hourglass pattern, whereas this is a horseshoe pattern with a tongue-shaped extension. Now this tongue-shaped extension, it indicates that there is an area of corneal steepening here, which should be very carefully evaluated, and all these horseshoe with tongue-shaped extensions are abnormal shapes. So moving on to the third point, third map, which is the thickness profile. Now what to look for in this thickness profile? So this map gives us the pachymetric value at all selected points of the cornea. And at no point, the pachymetric value should be less than 500 micron. It indicates a thin area. Also, in the 4 millimeter zone, the thickness between the superior and inferior corresponding points should not be more than 30 micron. Further, as I said earlier, the thinnest point displacement should not be more than 1 millimeter from the center of the pupil or the pachy apex. That means the y coordinate should not be more than 1000 microns. The thickness between the thinnest point and the pachy apex should also not be more than 10 microns, and the inter-eye difference at same location should not be 30 microns. With this information, we move on to the maps and its evaluation. So the first map, which you can see here, it tells us that this area is thinned out. You have got an island which shows the areas of thinning to an extent of 479, and the thinnest pachy is 463. So this is a suspicious case. You should not proceed for refractive surgery, and this patient should be evaluated for corneal steepening. This is a case of a pellucid marginal degeneration with inferior steepening. You can see the paracentral inferior steepening here with a range of around 287. Now, what is this? This shows a uniform thinning throughout the cornea. This is a case of keratoglobus with the uniform steepen and the thinning ectasia in the complete cornea. The next page of the thickness profile is the relation between the corneal thickness and its location. So the computer designs a map which takes into consideration 22 concentric circle, which is centered on the thinnest point with increasing diameters of 0.4 millimeter. So the computer will generate this image with the pachymetry and all these concentric circles from the center towards the periphery. And the same is displayed in this CTSP and the PTI plots. So these are the measured, the red line is the measured point of the patient, and these 3 dotted lines are the 3 standard deviation within 95% confidence interval of the age and the gender matched control. So in the normal patient, this red line should lie between these 3 lines, and it should lie along the center line. It should not leave this 6 millimeter zone. It should not leave the second line or the third line before the 6 millimeter zone. And the progression should not be more than 20% before 6 millimeter zone. So now look here, look at this. This is very, very suspicious. You can see that this red dotted line of the patient has left the 3 standard deviation line dotted lines before 6 millimeter. And there's a rapid progression from 5% to 40% here. So there's a rapid progression from a thin towards the thick cornea. So this is an abnormal thickness profile. It is also displayed in the irregularity indices, which you can see are all red. The keratoconus level also indicates that this is an abnormal case. Again, you can see the red line, which has left this 3 standard deviation before the 6 millimeter zone. So this is an abnormal thickness profile. To compare between a normal and an abnormal, I have put these graphs side by side. Here you can see there's no area of steepening. All the colors are colder colors, and the red dotted line of the measured points of the patient, it lies well within these 2 standard deviation. Whereas, look at the other side. There is an area of warm color. There is an area of steepening, and same is reflected in this CTSP or the progression index, where the red dotted line is out of the normal range. Now, this is a very interesting picture. Anyone would like to take this? You can see that the measured points are at 600 microns. That is a thick cornea and a straight line. So what is this? This is a case of corneal edema in a case of Fuchs dystrophy. Okay, so thick cornea with a straight line, it maintains it from the center towards the periphery. Whereas you can see here, it is a thinning area in the periphery and it moves upward towards the thicker side. So it is a case of paracentral thinning or a PMD. The irregularity indices, as I said, you don't want to memorize this. There's nothing to memorize. You can just interpret with the red and the yellow information which is given in the red and yellow, and you'll know whether it is an abnormal value. Something about the Bellin-Ambrosia enhanced display. That is the 4th point which I would be covering. So the bad display is very effective in identifying subclinical cases for managing patients of refractive surgery, also for IOL power calculations. So we must know the concept of enhanced best sphere. We earlier saw that what is the best fit sphere, that the computer collates all the measured points, all the refractive points, and makes it into a best fit sphere for that patient. Now, if the patient has got any isolated area of steepening, it will also consider that. So it will make an erroneous high steepened best fit sphere, which will mask this cone. Okay. Whereas in the bad display, it will exclude the thinnest area and a 4 millimeter around that area, so that you will have the actual best fit sphere, and which will actually measure the any area of steepening or elevation. So that exclusion zone is very important, and that is the complete concept of the enhanced best fit sphere. So this is the representative map, which is showing the bad display. This is the elevation map, and this is the exclusion map. So look here, there is no area of steepening and no elevation in the elevation map, which is the best fit sphere at 8 millimeter. But look here, after excluding the thinnest area of 4 millimeter around the thinnest area, you can see an area of steepening or a hot color here. And the difference map also has significance. So the difference and the interpretation is given at the bottom of the page, and computer gives you the information whether this is abnormal or normal. Again, a similar picture, you can see a case of steepening here, where you can see the inferior corneal steepening, which is more pronounced or more profound in the exclusion zone, or with the enhanced best fit sphere, and its difference is shown here, and all the D values are shown in red. So this is an abnormal case of steepening here, and you can also see a progressive corneal thinning from the center towards the periphery. The progression index also you can see is more than 1.2. It is 2.15 here. Okay, so this was all about how to interpret the corneal topography or the Schimflug-based imaging of the cornea. So these are the representative maps or some of the clinical cases of interest which I'd like to take here. So this case number 1, you can see that all the values on the anterior curvature of the sagittal map are within normal limit. The pachymetry map is also within normal limit. There are no warm colors. The anterior elevation is within normal, and the posterior elevation is all within normal limits. And also check that the quality specifications is okay. So this is a patient with a normal cornea. And also the same is depicted in the thickness profile. Now look here, the very interesting case, you can see some areas of steepening and some skewing of the axis. And in addition, it has got a corresponding area of thinning of around 459 microns in the pachymetry map. But when you see the anterior and the posterior elevation, it is normal. So this patient is just a case of astigmatism and not a case of corneal thinning. So this patient should not be, misdiagnosed as a case of ectasia. Now, case number 3, where you can see the very characteristic refractive power in the steep range in the anterior sagittal curve. The corresponding points in the anterior elevation is also showing elevation, the marked elevation. Posterior elevation also showing marked elevation, and the corresponding point in the pachy map is also showing thinning. So when you're identifying any such thinning or steep area, you should be able to identify or make sure that they are all on the corresponding point. So this is a case of keratoconus or an inferior steepening. Case 4. Now this is very interesting. Anybody would like to take this case? You can see a central area of flattening here and a peripheral area of steepening. So what could this indicate? This is a case of post-myopic LASIK or a oblate cornea. Whereas, look here, the opposite. There is a central steepening and a peripheral flattening. What this could be? This is a case of post-hyperopic LASIK or a prolate cornea. So that is all about the interpretation part, and the carry home message for you all is that interpret all the values carefully. Look for the quality specifications first. That is the most important thing, that the computer has taken all the images carefully. Also, the interpretation should be step by step. Do not jump onto any particular map and jump onto the indices. You have to take them systematically one by one. So this is, I just compiled all the data in one table for you all about the quality specifications, the sphericity, the pachymetry. I already told you that it should not be less than 500, less than 470 at any points, and the Y coordinate should not be more than 1000 microns. The anterior curvature map should not show any steepening more than 47 diopters and any skewing of the axis more than 22 diopters. The elevation map should be within 15 microns and within 20 microns in the anterior posterior float. The keratoconus diagram should not show an average keratometric progression of more than 1.2, and all the values should be shown in white, not in yellow and red. It should raise your suspicion. So thank you very much, and thank you for a patient hearing, and I hope that I did made the curves smooth for you all. Thank you. Thank you.
Thank you, Dr. Bhavna. I think you will go into the history of the AIOS, that you are the first speaker for this program. And very well explained. And only thing in the future, I requested Dr. Santosh, we should have the moderator given by the speaker itself, who is really expert in that subject and carry forward the discussion nicely. So, but in any way, I mean, it was very, very well and very simply explained. Thank you very much for being part of this program.
Thank you, Dr. Bhavna. I think you've given us an excellent understanding of the landscape of the cornea. And I would request the audience, all the people who are logged in, to please put in their questions in the chat box so we can take them. I also request all the panelists to ask questions if they have any. You can also join in the discussion. Most welcome. We do have one question here. It's a question on the application of corneal topography, that how often would you like to repeat a corneal topography in a patient with a form thrust keratoconus? How often should this be repeated? Dr. Bhavna?
Yes. So in my practice, what I do is we do, because the progression is taken every 6 months, so we repeat the corneal topography every 6 months and see for the progression if it is there, so the patient can be attended for any intervention if it is required.
Thank you. Thank you. And there's another question that which are the patients that we should subject, like a child comes in with a high astigmatism? Do all these patients need to be subjected to a corneal topography, or what are the the factors that give us a suspicion of
Yes.
keratoconus?
If the child is cooperative, of course, you can take. But as I said, that the basic investigations also of use here. That is the basic placido disc-based investigation of photokeratoscope we have got. If it shows an abnormal reading in an uncooperative patient, of course, we would not be able to image on a pentacam. But we can do with this investigations the basic, that is the photokeratoscope. And if it is showing any steepening, any isolated area of steepening, or any irregular astigmatism, we can subject later this patient to the topography. Yes.
Thank you. So I think we can move on.
One more thing, that we can also measure the corneal thickness from the OCT-based imaging system. So we can see that the corneal thickness is abnormal. We can also again evaluate this patient further. If it is normal, there's no need to see the patient on the pentacam.
So we have another question. Currently, which is the best form of topography, and what can be used at the level of a medical college with basic facilities? So these are some questions in the chat box, which people have been asked.
As I said earlier, that the three systems, that is the Galilei, the Pentacam, and the Sirius. So the medical colleges can acquire any of these. We have the Sirius topography system which works well. And other centers may have a Pentacam or a Galilei system, but the Sirius and Pentacam, they work well for all patients. And I think we can take the opinion of other panelists also in this discussion.
Dr. Uma Sridhar, would you like to?
Actually, thanks, Tinku. The tomography-based systems are ideal. Earlier, we used to use only the topography, the anterior topography. One advantage with the Pentacam is it gives the K max values. So many times the K1 and K2 or the K median are fairly okay, but the K max is very abnormal. So I think the Pentacam and the Sirius and the tomography-based systems, they give you, and keratoconus is basically a posterior thinning, and one has to be very careful with it. Most practitioners usually only have the anterior surface mapping. So like Madam said, a Sirius or a Galilei or a Pentacam-based tomography systems are more ideal. The other point that he said, when do you get a child with topography? I would prefer that any child with a history of eye rubbing or BKC or any allergies with high astigmatism or even low astigmatism, it's better to get a baseline topography done, so that over a period of time, when the cylindrical number increases, then one has a baseline value to fall back upon. So it's very useful to take a baseline value if the parents agree, and it's very quick acquisition with the pentacam. So for children, I think with astigmatism or with a history of allergy and BKC, better to get a baseline pentacam done.
So we'll just take one more quick
Just-
question.
Just one comment. I know certain places where the medical colleges don't have the facilities, but now the private setups are very good. And those students can go to the private setup, and these doctors won't mind they're coming over there and are learning their equipments. So I've seen some of the places actually having an arrangement of sending their students to the private setup. So I don't think anybody will mind if they go and learn anywhere. So if you have got a good setup and if you don't have a pentacam at your place, you can go to any nearby good setup and go and learn over there.
So we'll take two more quick questions. What is the role of topography in a complex cataract surgery, Dr. Bhavna? And
So-
is there any role of intraoperative topography?
Yes, so the topography is important. As I said, that the axial or the sagittal curvature is important in IOL power calculations. That is the sagittal. There's another topography that is the tangential curve. So that may not be important. It is a noisy, display. So that may not be important for IOL calculations. It is mainly for the corneal irregularities. So the sagittal curve is important. We take into consideration the refractive powers at various locations, the mean of them, and then it is transferred to the various IOL calculating formulas, and also the bad display sometimes can be incorporated into various formulas like the holiday to give you a reading of the IOL power, particularly in the toric IOLs, calculation of the toric IOLs. Yes.
Actually, if the corneal topography is haywire, then the reflection of the patient is more important than the topography, because the cornea power has changed at so many places from which cornea the patient is seeing clear and the best. So whenever the cornea is irregular, because I use toric IOL a lot in a post-RK patient and in the corneal keratometry, then they take what is the cylindrical power on the acceptance of the axis and glasses. That gives far better clue if the cornea is totally irregular.
And is there any role of intraoperative topography? Dr. Uma or any of the other panelists would like to take that.
Tinku, the Aura system developed by the Alcon guys, they do have intraoperative calculations, but I don't think, I don't know what Sir Dr. Harbans Lal is obviously a prolific cataract surgeon. He would have a better opinion. Many times when the patient is left faking on the table and Aura system is used, but that does not really take into account the corneal topography, And unless it's a very irregular cornea, I don't think intraoperative topography so far has been used. Sir would be a better person to answer this.
Intraoperative topography for cataract is actually not useful because we hardly introduce any astigmatism over there. But of course, for the corneal surgeons, when they are giving a sutures that you are doing a keratoplasty, and if you want to check over there the astigmatism, that may be useful, but not for the cataract surgeons.
Okay, thank you so much. So now we move on to our next topic. Our next speaker is Dr. Uma Sridhar. She's a senior consultant in the cornea and cataract services at the Eye Care Hospital, Noida. Fellowship trained from the L.V. Prasad Eye Institute, Hyderabad. Her areas of interest and expertise include cornea diagnostics, ocular surface disorders, ocular surface tumors, dry eye diseases, and stem cell transplantation for limbal stem cell deficiencies. An author of the textbook and atlas called The Cornea Illustrated Guide to Clinical Diagnosis. She has been the editor of the Noida Journal of Ophthalmology and also the president of the Noida Ophthalmological Association. With many awards and publications to her credit, I now invite Dr. Uma Sridhar to speak on her topic of choice, chemical injury. Dr. Uma.
Uma, you're muted.
I also request all the audience and the participants to kindly put in their questions in the chat box, which we can take later at the end of the talk.
Can I go back to my first slide? Yeah, 1 second. Is my screen visible?
Yes.
Am I audible?
Yes, loud and clear.
Thank you so much, Tinku. Thank you, Dr. Santosh and Dr. Harbans Lal. It's indeed a prestigious forum. And I hope I do justice to this topic, which is rather vast, but rather important. So for a student, practitioner, or any ophthalmologist, chemical injuries and the diagnosis and management is extremely important. We may first see the patient in this manner when do a fluorescence staining. And if not properly managed, they end up in this form with complete pannus and there is no vision, and then the management becomes very difficult. So the initial management of a chemical injury, which is a true ophthalmic emergency, is extremely important. The incidence of chemical and thermal injuries to the eye could be between 7.7% to 18% of all ocular trauma, but it differs in various studies. The chemical injuries of the eye may produce extensive damage to the ocular surface epithelium, cornea, and anterior segment, resulting in permanent unilateral or bilateral visual impairment. 80% of chemical burns are due to industrial or occupational exposure, males more than females, and lime burn, that is tuna packets, are used, very common in India. The other most disturbing one is the acid injuries, which are which are also very common, and they may cause intense damage by a jilted lover or anything like that, or by because of revenge or any such thing. This also causes intense loss to life, limb, and to eyesight. Now, the ocular chemical burns can be caused by alkalis and acid, and the various alkalis and acid are seen in this picture. At home, the common offending agents are cleaning solutions, drain cleaners, oven cleaners, bleach, battery explosion. Industrial exposure to alkali can also happen. Noida is an industrial belt, and we do see a lot of chemical injuries in this area. There are also textile factories which use peroxide, and there are battery, many times people cleaning their car batteries or they also have battery acid injuries. And we have hydrofluoric, HCl, and sulfuric acid. And also there could be accidents in the lab. So the alkalis could be ammonia, sodium hydroxide, potassium hydroxide, calcium hydroxide, and the acids could be sulfuric, sulfurous, hydrochloric, and hydrofluoric acids. So as I said, battery acid and industrial cleaners, alkalis as in ammonia, and fertilizers and refrigerants, acetic acid as in vinegar, glacial acetic acid, and hydrofluoric and sulfurous acids in chemicals, in bleaches, in refrigerants, and also in the when the workers are in the there are many industrial areas where buildings are being constructed, plaster, mortar, cement, which is one of the worst injuries, whitewash and caustic potash, hydrofluoric acid in glass polishing and etching, potassium and magnesium hydroxide, especially in cracker burns and incendiary devices. The severity of chemical injury is related to the type of chemical, the volume, the pH, and the duration of exposure. So immediate response at the site should be washing. With what solution, how much, and for how long, we will discuss. So I have also put a few MCQs, which I will answer at the end of the talk. So the first MCQ is, which is more effective? Tap water, ringer lactate, BSS, diphotherine, or option B, diphotherine, ringer lactate, normal saline, BSS. Option C, diphotherine, BSS, ringer lactate, normal saline. Phosphate buffer, diphotherine, BSS, ringer lactate. At the site, whatever solution is available has to be used. Tap water is hypotonic, but if nothing else is available, obviously this is what we have to use. Get rid of the chemical or dilute it. Normal saline, ringer lactate, BSS, polyvalent amphoteric solution, that is diphotherine, are useful. Now, the management in the immediate phase would be wash copiously, but it is hypotonic, and buffered solutions, they can correct the pH. purpose-designed solutions, they are isotonic to the stroma and in a clinical setting, and like diphotherine, which is hypertonic, rapid pH correction, and faster reepithelialization. The choice of most effective solution is equivocal. Published reports are limited to in vivo experiments in animal models and at best small observational studies with significant limitations. And given the importance of prompt and continuous treatment, the most immediately available and sufficiently abundant solution should be utilized. Now, here you see the effective use of a Morgan's contact lens if it is available. So after anesthetizing the cornea with a topical anesthetic, insert the Morgan's lens and wash copiously. And then after removal of the lens, evert the eyelid and check for any particles. Now, the second MCQ is alkalis penetrate more because A, acid saponification of cell membranes, B, alkali saponification of cell membranes, C, acid coagulation of epithelial proteins, D, alkali coagulation of epithelial proteins. MCQ 3, which alkali is more severe? Sodium hydroxide, calcium, ammonia, potassium, or in this order, calcium, potassium, sodium, ammonia, ammonium hydroxide, calcium, sodium, potassium, calcium, or potassium, sodium, ammonium, calcium. Now, the acids and alkalis, how do they differ in their mode of action? The acid causes denaturation and precipitation of proteins on contact, causing a ground glass appearance. It causes a barrier to further penetration. The damage to somal matrix is secondary to inflammation. Alkalis cause saponification of fatty acids in cell membranes, but they are hydrophilic and lipophilic, so they cause rapid penetration and damage to deeper structures. Alkalis cause maximum damage in a pH range of 11 to 11.5. They dehydrate cells, they destroy enzymatic and structural proteins. Ammonium hydroxide causes a rapid penetration followed by sodium, potassium, calcium. The heat generated by chemical reactions cause additional damage. A cracker burn has causes thermal as well as chemical injury. So there is a bimodal way of damage. Ocular response to chemical injury. So what happens? Conjunctiva gets cauterized, the corneal epithelium sloughs off, the stroma swells and opacifies, the endothelial cells die, the angle structures scar, leading to intractable glaucoma, and the lens opacifies. Weak acids and alkalis, they cause injection, chemosis, mild corneal clouding, and edema. Severe acid burns, the cornea and conjunctiva are white and opaque. Nitric acid and chromic acid, the tissue becomes yellow-brown. Severe acids can cause corneal anesthesia, limbal pallor, and uveitis. Severe alkalis can cause corneal melting and perforation in 2 to 4 weeks. The extent of limbal injury is important because the tissue needs re-epithelialization. So what is the most important prognostic factor immediately after ocular chemical injury? Chemosis, conjunctival epithelial defect, limbal ischemia, or corneal epithelial defect. The clinical course of chemical injury, as I said, the pH, the concentration, and the length of time of contact is important. So what is the clinical course of a chemical injury? Immediate phase, acute phase, early reparative, and late reparative phase. In the acute phase, first 7 days, the most important therapeutic consideration is prompt, unhindered re-epithelialization. Whether the cornea and the ocular surface is epithelialized by the corneal epithelium or the conjunctival epithelium on the cornea doesn't matter. You need an epithelium. Control of ocular inflammation is the second most important therapeutic consideration in this period. Look at the corneal clarity, the intraocular pressure, due to shrinkage of ocular collagen, and later release of prostaglandins can occur. So the fallacy that if there is an epithelial defect, do not give steroids does not matter in this, is not important. You have to give anti-inflammatory and steroids regardless of whether there is an epithelium or not. The early reparative phase is 8 to 20 days. Chronic inflammation, stromal repair, and scarring occurs in this period. And again, the most important goal is the establishment of an intact epithelium. Otherwise, there is a stromal melt, and to control ocular inflammation. In the late reparative phase, there is a loss of corneal sensation, a reduction of blink reflex, and decreased tear production. And severe injury can lead to pannus formation. And the aim is to maintain the epithelialization because surface breakdown can occur at this stage, and to lubricate the ocular surface. The key elements for prognosis is the total area of corneal epithelial defect, the area of conjunctival epithelial defect, the number of clock hours or degree of limbal blanching or limbal ischemia, the area and degree of density of corneal opacification, the evidence of increased IOP on presentation, especially if it is resistant to treatment, and any loss of lens clarity. The last two elements imply deeper effects of chemical agent and damage to the inner ocular structures. So patient treatment and evaluation. The pH strips are extremely useful. This is easily available on Amazon and you can use it. No financial interest here. So it is good to know the pH, and after you test the pH before washing and after washing. And also, if you have access to an Octa, which compares the limbal ischemia, here this picture in this wonderful presentation shows 360 degrees compilation of the limbus prior to tenonplasty and improvement in vascularization in terms of vascular density after tenoplasty. If you have access to Octa with measures, we have an Octa, but does not show the anterior surface, unfortunately. Clinical classification of chemical and thermal burns. Eye burns are classified in 4 grades by Ream. The clinical course and ultimate prognosis correlates with the extent of limbal ischemia and the Hughes, Balin, Roper-Hall's classification. Prognosis also depends upon the extent of damage to the conjunctiva and episcleral tissue, severity of lid burn, and damage to intraocular structures. So the 5th MCQ is Dua's classification. What is it based on? Cornea, limbus, and lid, cornea, limbus, conjunctiva, and lid, limbus and conjunctiva, or limbus, conjunctiva, and lid. The classifications are based on the total area of corneal epithelial defect, conjunctival epithelial defects, number of clock hours of limbal blanching, area and degree of corneal opacification, evidence of increased IOP on presentation, and loss of lens clarity. So we have the Ralph's classification where the prognosis score, total score determines the prognosis. So you have different values given to each of these, like you can see perilimbal ischemia and chemosis and clouded epithelium. But more severity is given to, the severity of stromal haze, sustained intraocular pressure. And you can see that perilimbal ischemia, epithelial loss, and sustained intraocular pressure are given more points here. So here also 0 to 3 is insignificant and there is a rapid recovery expected. 4 to 6 is mild, and again you can have rapid reepithelialization. So it's useful to prognosticate to the patient what the ultimate result would be. 7 to 9 is moderate. So moderately severe burn can lead to a stable pannus. 10 to 12, you can have slow reepithelialization, can have perforation, and have reduced visual acuity. And when the score is more than 13, there is dense pannus, perforation, vascularized scar, and may not retain the globe too. So the category in Hughes classification was mild, moderately severe, and very severe. In the mild, you had the epithelial erosion, faint haziness of the cornea, and no ischemic necrosis of conjunctiva and sclera, whereas in moderately severe, there is blurring of the iris detail, and in very severe, the pupillary outline cannot be seen, and there is severe ischemic necrosis. Thorpe's classification, you have grade 1 to 4. The grade 1 and 2 are good. The grade 3 is guarded, and the grade 4, it is very poor. Now, the modification of by Roper-Hall, you can see that the grade 1 and 2, they recover very well. The grade 3, there is guarded prognosis. Grade 4, there is poor prognosis. Harminder Dua has modified the classification, but then again to reiterate, you can use a combination of classification. It is not that just because Dr. Dua's classification has come, the modified Roper-Hall does not hold water. You can use a combination of the two. Now, the prognosis in grade 1, 2, and 3 is good. And the conjunctival involvement is less than 50%, whereas grade 4, 5, and 6 would be the Roper-Horn's 4 and 5, and the prognosis would be guarded to poor in 5 and very poor in 6. The analog scale records accurately the limbal involvement in clock hours of affected limbals divided by percentage of conjunctival involvement, while calculating percentage of conjunctival involvement, only involvement of bulbar conjunctiva up to and including the fornices is considered. Now here you can see grade 1, no area of limbal ischemia, no conjunctival involvement. Less than 3 clock hours, less than 30% would be grade 2. Grade 3 would be less than 3, more than 3 and less than 6 clock hours of limbal involvement, with more than 30 and less than 50 of conjunctival involvement. Grade 4, here you can see it's far more. There is less than 9 clock hours, but there is also less than 75% of conjunctival involvement. Grade 5, more than 9, less than 12 clock hours of limbal involvement, and more than 75, less than 100% of conjunctival involvement. And grade 6, of course, 12 clock hours of limbal involvement and 100% of conjunctival involvement. So here you can see one example of grade 5 or grade 6 level. It is an emergency. You have to remove the offending agent, stop further damage, promote epithelialization, minimize ulceration, reduce inflammation, and control IOP. So with these aims in mind, your treatment would start: prompt irrigation, anesthetic drops, passive opening of eyelids, asking patient to look in all directions, wash conjunctiva and cornea. You can use a cotton-tipped applicator soaked in 1% EDTA to remove lime particles. So you also, the American National Standard says at least 500 to 1,000 ml, of normal saline ringolactate BSS. Avoid hypoosmolar. Diphotherine is 0.4%, pH 7.4, osmolarity of 820 milliosmoles per liter. So far, I have not had access to diphotherine, but of course, if you can get it, would be wonderful. Till pH is outside normal range, please keep washing. You can use the universal pH indicator paper. Debride the necrotic conjunctiva, cornea, and subconjunctival tissue to remove the nidus of continuous inflammation and sustained release of proteolytic enzymes. If you can record the visual acuity, it is important. See the pupillary reaction, examine facial skin, eyelids, lashes, lacrimal apparatus. You can do a penlight or slit lamp examination if the patient allows to see epithelial loss, corneal opacification, limbal ischemia. Here is one condition where white eye is worse than red. Limbal ischemia, clock hours of blood vessel loss of conjunctival tissue where it reaches the peripheral edge of the cornea. The study has been done by Cam et al., where I was part of the examination in LVP when there was an ocular surface meeting where all of us were given pictures of limbal ischemia, and the correlation between different practitioners actually varied. So the picture on the immediate and also a little later after 10 days, the blanching may not necessarily mean ischemia. Areas of subconj hemorrhage may also indicate areas of ischemia. So the picture in the first day and after 10 days may actually vary. If you have access to Okta, would be good. One of our colleagues, Dr. Bhaskar Roy Chaudhary, has made a device, has made an application where you can see in that software, you can see areas of limbal ischemia and vascularization. I hope he patents it soon. And the fluorescence staining can show corneal epithelial loss. The IOP can be measured digitally. You can also use a toner pen. Posterior segment evaluation, if possible, under dilatation. So one has to promote re-epithelialization, tear substitutes, ideally preservative-free with or without punctal occlusion. Bandage contact lens can also be used to protect the ocular surface from windshield wiper effect. Investigational drugs like fibronectin, epidermal growth factor, retinoic acid, umbilical cord blood, amniotic membrane suspension, autologous serum, platelet-rich plasma have been variously used. To promote corneal repair and minimize ulceration, sodium citrate 10% topically decreases PMN accumulation. Now, once I think the question will be asked, is sodium citrate available? You can give Vacutainers with a blue lid, and there you can prepare sodium citrate. I think online it shows how to prepare the sodium citrate 10% topically. They are available in the form of Vacutainers, like EDTA also comes in Vacutainers. You can use that. Sodium ascorbate, topically 10%. Some pharmacies like All India Institute, they do provide 10% ascorbic acid. You also have ascorbic solutions which you can use, but ideally we have mostly used systemic ascorbic acid. 2 gram QID is the textbook dose, but if you can give even 500 mg 4 times a day or 1 gram 4 times a day with sufficient hydration, reduces incidence of ulceration. One more tip about ascorbic acid: it is said that the intermediate phase one should not use steroids, but textbook teaching and also many literature references tells us that if the aqueous has sufficient amount of ascorbic acid, you can continue to use the steroids even in the intermediate phase. Tetracycline reduces collagenase activity. There is chelation of zinc at the active site of matrix metalloproteases release. It inhibits polymorphonuclease activity. Doxycycline 100 BD, tetracycline or minocycline can be used. Collagenase inhibitors like acetylcysteine available in the market, yes, in some pharmacies. Sodium EDTA, calcium EDTA, and penicillamine. Acetylcysteine has been used clinically and it is available. Now, topical autologous serum drops also promotes epithelialization just than standard therapy. There have been papers by Dr. Namrata Sharma et al. On umbilical cord blood therapy too. The sixth MCQ is the role of vitamin C. It decreases inflammation, promotes epithelial healing, prevents collagenolisis, promotes collagen synthesis. So that was the last MCQ. There are many studies on the preparation of ascorbic acid drops, and one can refer to this, and also sodium citrate and ascorbate drops preparation. Now, the algorithm that we have seen, this which is important, is one sees whether there is suspicious areas of ischemia. Of course, start medical management, intense topical steroids, and you can see the reperfusion. No surgical intervention if there is no area of ischemia. If there is sectoral ischemia, you can perform permanent tarsorrhaphy, then observe. Established ischemia, you can do a sectoral tenonplasty, amniotic membrane graft, and a permanent tarso 2. Total ischemia, then a tenonplasty and an amniotic membrane graft in a central permanent tarsorrhaphy. And you can also see that if there are clear delayed presentation comes more than 1 week later, can start medical management with intense topical steroids. Sectoral ischemia, then sectoral tenonplasty immediately, plus or minus amniotic membrane graft, permanent paramedian tarsorrhaphy. Total ischemia, then tenonplasty, AMG, and permanent tarsorrhaphy can be an immediate management. The corticosteroids decrease the first and second wave of inflammatory cell infiltration. They decrease collagenase production, stabilize polymorphonuclear leukocytes and lysosomal membranes. They impair stromal wound healing, but this is the flip side, by inhibiting keratocyte migration and collagen synthesis. NSAIDs, I would not really prefer, but one can use NSAIDs. Preferably, corticosteroids would be better. Citrates are calcium chelators and they inhibit collagenase. Prophylactic antibiotics, cycloplegics, and anti-glaucoma medications can be used. Surgical management in the immediate phase could be debridement, amniotic membrane transplantation, tenonplasty, tissue adhesives, and alloslit. So when do you think of amniotic membrane transplantation? May not be on the first day. If it is an immediate presentation, watch for 3 to 4 days. If it is not healing, if the epithelial defects don't show healing margins, preferably to go for amniotic membrane transplantation if it's available. Of course, you can use fresh amniotic membrane if they have been properly vetted and cleaned, and you know that there is no HIV, HCV, or HBsAg. So in acute burns, within 1 week of ocular surface burns, they could be removed 7 to 9 days later, tested for expression of CD15, 68, 20, etc. It traps the inflammatory cells, induces apoptosis of inflammatory cells. It can be performed in acute, early, and late reparative phase. It has anti-angiogenic, antiseptic, promoter of epithelialization, analgesic, antifibroblastic properties, keeps adhesive surfaces apart, can be used as a graft or a patch. In short, a magic membrane of Schaeffer-Seng. So it decreases inflammation, reduces scarring, decreases vascularization. So here was one patient with thermal injury with amniotic membrane, healed pretty well. This was a patient who fell on dye that is in a textile factory. Here you can see the peroxide burns can cause corneal emphysema, and you can see air bubbles in the cornea. The next day he was like this. We advised amniotic membrane on the first stage, did not agree. He went to All India Institute. He was given AMG was done by Dr. Vanati, and he stabilized with that initially. And this is one video which I would like to tell you that after a preliminary amniotic membrane graft, the advantage of doing an amniotic membrane immediately is it gives a very beautiful plane for pannus dissection. So in this case, here you see the pannus looks pretty bad. But if you see when the pannus, it can be easily peeled off. So when it's easily peeled off, you can see that the undersurface is pretty good here. Can I get it ahead? Huh. So when you take it off, look at the pristine undersurface after removal of the pannus. Then here you can do, that is because in the initial phase, an amniotic membrane graft was done. You can repeat an amniotic membrane graft after 2 weeks or 3 weeks. The other procedure that I would ask people to do it, it's not so difficult, is to, after the amniotic membrane graft, you can anchor it or you can use fibrin glue, and better to do a tarsorrhaphy. So if you have, you can do a temporary tarsorrhaphy. So have a short fuse for tarsorrhaphy and for amniotic membrane graft, because if you do an amniotic membrane graft in the initial phase, then the pannus can be easily dissected out. And later, of course, conjunctival or tenon's advancement is suturing the vital connective tissue in the orbit. You excise all necrotic tissue, followed by blunt dissection of tenon's tissue from the equatorial region of the globe. Advance the tenon's flap, which is carefully preserved vascular tissue, onto the limbus. In cases of impending perforation, a thin conjunctival flap from ipsilateral or contralateral eye or mucous membrane grafting can be performed. Tenonplasty is useful in grade 5 and 6 burns. And this is one case from the LV Prasad Institute, where it shows inferior sectoral tenonplasty following alkali burns. And here you can see that the inferior ischemia, which was subtle in the early phases, you can see that it was more evident on day 10, and it persisted despite amniotic membrane transplantation. So here a tenonplasty, you can see a recovery after 4 weeks. So this is the usefulness of this simple procedure. Now there is another from the same institute, there is another successful outcome, 360 degrees after 360 degrees of tenonplasty. A 34-year patient with 360-degree limbal ischemia following an acid injury presenting after 1 month. He underwent a simple limbal epithelial transplantation followed by penetrating keratoplasty and cataract surgery, and did fairly well. So the surgical steps involved in the combination of tenonplasty plus AMG, you can see the chemically injured eye had conjunctival necrosis and limbal failure. The defective conjunctiva and ischemic sclera reached up to the fornix. The conjunctival border along the necrotic sclera was granulomatous. The conjunctival edge surrounding the necrotic area is open, and the adjacent tenons is separated from the neighboring area beneath the residual conjunctiva. The separated tenon tissues are freed and they are fixed to the ischemic sclera, and the amniotic membrane was trimmed to fit the conjunctival defects, and the entire cornea and the ocular surface is covered and fixed to the surface using 80 vicryl sutures, and also 2 sides away. So you can anchor it at the limbus with 10-0 nylon or 80 vicryl, and also peripherally, so that it does not get peeled off with every blink. Of course, a tarsorrhaphy also helps at this stage. Tissue adhesives can be used in small perforations, whereas emergency patch graft or therapeutic PK for large perforations. But one has to be careful because of lack of limbal stem cells, an early melt can occur. AIOS. When there is a bilateral injury, a simple mechanism to be used is AIOS. The questions asked for AIOS is, do you use any immunosuppression? No, you do not use immunosuppression at this stage because you're using it at an acute stage. You just want epithelialization. And at this stage, you don't need to have an immunosuppression. Once the epithelialization occurs, of course, even if it fails, it does not really matter. You can use a living related slet in case of bilateral conditions in a later stage. or of course, you have the options of keratoprosthesis and so on. So the management in the intermediate phase is structural reconstruction and ocular surface restoration. So what is the proposed classification of epithelial transplantation procedures? You have a conjunctival autograft from the fellow eye, you have cadaveric allograft, you have living related, you have conjunctival limbal autograft from the fellow eye, you could have a cadaveric conjunctival limbal allograft, a living related, or a keratolimbal allograft. The management overview of unilateral versus bilateral cases. In grade 1, in unilateral cases, medical management suffices. Grade 2 and 3, medical plus minus AMG. Grade 4, 5, and 6, medical initially, a later conjunctival limbal graft from the other eye, and simple limbal epithelial transplantation or a cultivated limbal graft if you have access to it. In bilateral cases, grade 1 medical, grade 2 and 3 medical plus minus AMG, grade 4, 5, and 6 initially medical, then tenoplasty, cultured limbal stem cells from a living relative, or oral mucosal transplant that's called COMET, or keratoprosthesis. There are several studies in the successful management of chemical injuries by Mittal et al. And also there are cases of outcome of cataract surgery following limbal stem cell transplantation for Lyme injuries. And there are many studies now with SLET, which has been introduced by Dr. Sangam et al. And here, this is a novel surgical technique, no longer novel because Dr. Sangam et al. Have popularized it world over. A 2 into 2 mm donor tissue divided into 10 pieces placed on amniotic membrane, and like it is an in vivo culture. So the eyeball itself, the corneal surface is used as culture. There are several ways of doing it. You can put your explant buttons directly on the cornea. You can put the amniotic membrane, stick the buttons there, and then put a bandage contact lens. Or you can do a sandwich technique, put the amniotic membrane, put the limbal stem cells, put another layer of amniotic membrane, and put a bandage contact lens. So there are several ways of doing limbal stem cell transplant. Here are two examples where you can see the explant button on the eye. Now the preferred way is not to leave the central area open so that and put the buttons in the paracentral area. Penetrating keratoplasty after autologous cultivated set has also been done, and PK plus limbal stem cell in 2 stages has been found to be better than a single stage procedure. What happens if there is limbal stem cell deficiency, or what are the complications of chemical injury, a non-healing epithelial defect? There could be conjunctivilization, pannus formation, or melt. There could be corneal opacities, cataract, glaucoma, ultimately leading to phthisis, dry eye, lid malposition, symblepharon, trichiasis, and more scarring. Late rehabilitation in cases of diffuse limbal stem cell deficiency, keratolimbal allografts, conjunctival limbal autograft, cultured limbal stem cell, large diameter therapeutic PK, penetrating keratoplasty, or keratoprosthesis. How does a limbal stem cell deficiency look? Late fluorescent staining in the superior peripheral cornea, stippled fluorescent staining pooling in the same area, and there could be vascularization, and a persistent epithelial defect may also be there. So there are different ways of examining for limbal stem cell deficiency. If you have access to a confocal microscopy, you can see that in the first picture, the basal cells in the normal cell, the cell size is small, the cell borders are distinct. In moderate degree, the cell size is large, cell borders are indistinct. Totally, there is a loss of corneal epithelial cells and severe vascularization, and inflammatory cells are present. Keratolimbal allograft we have done from cadaveric donor tissue and transplanted to burnt cornea under oral immunosuppression. This is one example of 20 years ago when we didn't know anything about SLET. It had not been invented. Even the cultivated limbal stem cells were not available. So from Ed Holland's papers, we had tried to do a keratolimbal allograft. Then there came Zaya's papers, which said about how the keratolimbal allografts can fail without immunosuppression. Conjunctival limbal autograft could be taken from a contralateral uninvolved eye in unilateral cases, or living related donor in case of bilateral involvement. Cultured stem cells were the flavor of the month years ago. It needed a clean room, a stem cell lab. Even now, people are using it to make cultivated cells, but it is an expensive process. And there is It's ex vivo expansion of limbal stem cells. But from the onset of SLET, I think the corneal surface alone is used as a culture plate. Autologous oral mucosal epithelial transplant was described by Kinoshita, the use of autologous cultivated oral mucosal epithelial cells. But here you can find there's a lot of vascularization in comet as compared to the corneal surface, as compared to the cultivated limbal stem cell. Xenografts have also been used, and people have even tried transplanted human endothelial cells. So this is one area of tissue engineering which may take care of the endothelial cells in a not so distant future. Nasal mucosal grafts, the hard palate grafts are thickest, and the oral mucosal graft, then the oral mucosal graft contract the least. They contain goblet cells that may contribute mucus to the tear film. This is maximized in the turbinate mucosal grafts, which can relieve discomfort. Nasal septal cartilage contains fewer goblet cells but adds rigidity. A large diameter therapeutic penetrating keratoplasty has been used in severe chemical injuries and also gives early visual rehabilitation, but high chances of failure. Keratoprosthesis is indicated in bilateral severe injuries with irreparable ocular surface damage or when corneal transplants are repeatedly rejected. It is said that when your fourth transplant is rejected, then there is no point. You have added a lot of immunological material to the surface. So your fifth, sixth, and seventh are just going to reject very rapidly. So better to use a keratoprosthesis. So here you can see parts of a Boston K-Pro, and then the most difficult one being done in many places is the modified osteoodontokeratoprosthesis. Takes many, many hours of the surgeon's time, many, many months. Not the most easy procedure, but successful osteoodontokeratoprosthesis can give good vision for many years to a patient. So the answers to the MCQs, which is the most effective, is C, diphotherine, followed by BSS, ringolactate, and normal saline. MCQ 2, the alkalis penetrate more because of alkali saponification of cell membranes. MCQ 3, which alkali is more severe? Ammonium, sodium, potassium, calcium. Most important prognostic feature is limbal ischemia. Dua's classification talks about limbus and conjunctiva, and role of vitamin C promotes collagen synthesis. Thank you for your attention.
Thank you, Dr. Uma Sridhar, for a very detailed exposition of the early and late management of chemical injuries. So I would request the panelists to put in any questions if you have. Dr. Lal, any questions?
I think it was really very, very exhaustive and very nicely covered, actually. And it's such a tough topic to really and to cover it in just such a short time. It's a great teaching tool. I think for many more years, and the students will keep on learning. There may not be very good attendance as of now over here, but these classes, the people, because it will be onto the our website, and we are going to popularize, and there are many more people go and read over there. So it is a very good resource material. As we have started the PG teaching program, which is Prashant Bhavan is running, now the views are running into thousands of that. So initially people may not attend, but I'm sure there will be many more people who will be benefiting from this. So very good talk. Thank you very much for covering all aspects of it.
Thank you, sir.
So I will take a leave now. I got to go ahead.
Thank you. Thank you, sir. Thank you for your presence. So we have a few questions from our PGs. One is that recently there's been a lot of talk on topical insulin drops for persistent epithelial defects. So do they have a role in this context?
Topical insulin drops, Tinku, have been used more in neurotrophic ulcers, not in chemical injuries. So the usefulness in chemical injury is still, the jury is out. We have not used in chemical injuries, but yes, it has been used in neurotrophic ulcers. So one thing the PG should understand, that it is not one thing has been produced, so it should not be used for everything. So it's not, so far the use is limited to neurotrophic. And there also, there is no long-term studies. So there are few anecdotal reports, maybe a few case reports, but it's more useful in that area.
And there's another question that in acute corneal perforations, what is your glue of choice, cyanoacrylate glue or fibrin glue?
The fibrin glue has no tensile strength. So the cyanoacrylate glue is the preferred one. And less than 2 mm only, it is useful. If it is larger than 2 mm, you have to keep another support for it. If you have to keep a patch graft or a Tenon's patch is being used, especially in the COVID era, that is the most common thing, and it has much more tensile strength.
And there's another one. What is the role of oral tetracyclines in acute chemical injuries?
Of course, there is a role. Either you use doxy or tetracycline to prevent collagenolysis. The vitamin C helps the collagen build up, and this prevents collagenolysis. So these are two, of course, less than adolescent age, you cannot because of fusion of the epiphysis and all that. But over that age, you should be giving this for a long term.
Thank you. Any of the panelists has any questions, any comments? You're most welcome to, join in.
Yes, so after this very elaborative, exhaustive, and a very informative talk by Madam, I would just like to add that for the PG theory and for the practical point of view, the theory questions are based mainly on the pathophysiology, which was very extensively covered by Madam. So the pathophysiology and its correlation to the treatment offered. So this is the most important question which we come across, and also the recent advances in the management of chemical injuries. So like the pathophysiological aspect, like how is the vitamin C involved and which stage is involved, citrates, which stage, the steroids in which state. So that is important, maybe asked in theory. Whenever there is practical exam, the student is expected to present the case along with the grading of the alkali burn, the clinical examination, and what will be the management per se of that particular patient. So it should be like a acute chemical injury. You should describe the acute chemical injury management. If it is done properly, you may move on to the management of the chronic cases and the management of complications. Just to add on the recent advances that the PGs may be interested to know. And there are recently reports of HLA matched limbal transplants, and also the Cincinnati protocol, which was asked in last exam of ours, and also the COMET, other types of limbal transplant, which the madam has already said. Just few to add few which have been, maybe of interest to PGs. And I think that's all from my side. Thank you.
So just a couple of more questions. Do you rarely use pH paper when you lavage the ocular surface in an acute chemical injury? Is there any role for that? Checking the pH?
I do. I have been using it. And there are many cases of drug toxicity also, which I use the pH paper. We had a recent interesting patient who looked like chemical injury but had no history of any chemical following to the eye. I tested all the drops used by her, and the pH was like 2. It was all red. All the drops were red. So it's very useful when a patient has a drug toxicity. You examine the drug, you know that the drug is not stable anymore. And also in chemical injuries, I always carry pH paper with me, and I encourage my students to do so. It's easily available now.
So a very important point that has been highlighted in the chat box is that it's important to prevent advocacy to prevent chemical injury, make people more aware of these injuries and their initial management. So what do you suggest? How should we go about it? Or is there any such campaign being done by the Corneal Society or any other society to actively
I think there is a lot of advocacy against acid throwing and all that, and I think legislation is probably coming up. And industrial based thing, there is obviously protection in the industrial it's there, and in the laboratories, industry, where it's the most common. And I think the Cornea Society is trying to do something against tuna packets, which are very commonly used in pan and all that. And the thing is, the kids take it and they burst it in their hands, and disastrous effects. So in the village areas, especially, the whitewash and the lime burns are very common in India. So I think there is something being done to prevent that, and also legislation against acid throwing and strict punishment for that.
Yeah, I think that's a very important thing that needs to be taken care of, the legislative part of it. And one more question, which I think you would already have covered, is the role of mega dose vitamin C and steroids.
Yes, ideally, we were asked in our fellowship days, if we didn't say 2 grams QID, we had to write it down 500 times. So, but I think 2 grams QID is very difficult to give. So, minimum at least 1 gram QID, if the patient cannot tolerate it, 500 mg QID, but large doses are definitely very important in the initial phase.
Mhm. And also, what is the choice of ocular hypotensive agents? Like they say, brimonidine drops cause vasoconstriction, so should be avoided. So, is there any such oral?
You wouldn't, simplest is obviously your timolol. You can also give, and I don't know why people will not give something like dorzolamide and all. It's not going to, in the short term, cause any endothelial damage because of carbonic anhydrase inhibition and all. You can give that. And oral Diamox, that is acetazolamide, is good enough. Yeah.
Okay.
The prostaglandins actually to be avoided in the initial early inflammatory period. The rest we can give the timolol and brimonidine.
Okay. Okay, thank you so much. I think we've covered all the questions that were in the chat box. So now we move on to our next speaker. She is Dr. Shweta Malagundla from the Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, Bangalore. A postgraduate of the Regional Institute of Ophthalmology, Minto Ophthalmic Hospital. She went on to do a fellowship in cornea and external eye disease. She's a phaco-diffractive and cornea surgeon with a special interest in ocular surface disorders and ophthalmic imaging, particularly of the endothelium. She has been awarded multiple times for her excellent corneal photographs and for her innovative smartphone photography of the corneal endothelium. Passionate about teaching, she's currently working as an assistant professor at the Regional Institute of Ophthalmology, Bangalore. She will be speaking on her area of interest, corneal endothelium, and its applied aspects. So over to you, Dr. Shweta. Please share your slides.
Thank you so much, ma'am, for your kind introduction. At the outset, I would like to thank the All India Ophthalmic Society, Dr. Harbansh Lal sir, Dr. Santosh sir, and Dr. Tinku ma'am for giving me this wonderful opportunity to present at the inaugural session of AIOS Guru Sangam. And I'm also humbled and happy to share the platform with the eminent panelists present over here. So I'll be speaking on corneal endothelium and its applied aspects. Why a 30-minute talk on just one layer of cornea? The corneal endothelium, which has an excellent
biology. Make it full screen.
Yes, sir.
Go to show, yeah. Slideshow.
Slideshow. It is on slideshow, sir.
We're only seeing the overview here. Sunil, can you guide? Maybe click on it again, slideshow, the orange thing.
Slideshow, yeah. Or you can stop share and do screen share again.
Yes, yes. Desktop share. Current slide.
Yeah.
Is it visible?
Yeah.
So the corneal endothelium, sorry for the technical error. The corneal endothelium, which has excellent biologic properties and a limited regeneration, has been a substrate for many surgical innovations and also for regenerative bioengineering. So the next 30 minutes would focus on discussing the structure of the endothelium and the functions of endothelium, how to examine the endothelium, identify endothelial dysfunction, a short note on specular microscopy, and also review the recent advances on endothelium and its dysfunction. So it is the PAC6 gene, which is the most important gene for ocular development. So the endothelium is derived from the neural crest cells. At 5th week of gestation, the neural crest cells migrate and they form the secondary mesenchyme in coordination with the transduction factors and with the help of this PAX6 gene, it forms the endothelium. It is the first wave of neural crest cells which gives rise to the corneal endothelium, which is double layer in fetal life, becomes a hexagonal monolayer at later stages. So this is the timeline at which the corneal endothelium is formed. At 5 weeks, there is migration of the first wave of neural crest cells, and at 8 weeks, a monolayer of endothelium is identified, and at 12 weeks, a histologically recognizable desmoid membrane is found, and at 5th month, the structure of the endothelium is complete in terms of tight junctions and a complete barrier being established, and at 7th month, it resembles the adult cornea. The characteristic feature of a neural crest derived cell is the expression of neuron-specific enolase. Though this neuron-specific enolase is expressed in smooth muscle, heart, and kidney, this can be used as a diagnostic tool for identification of endothelial cells. A monoclonal antibody has also been generated to serve as a specific marker for endothelial cells. So can we classify the endothelial cells based on neural crest origin? Yes. The first would be the defective formation of the neural crest origin. Though the corneal endothelium is not directly involved, it is basically the orbits and presence of a single eye, the entity being cyclopia. And the next most common is the Peters anomaly due to defective migration of the neural crest cells. It is the most common cause of congenital corneal opacity. And ICE syndrome due to defective proliferation of the neural crest cells, and Fuchs dystrophy due to terminal differentiation, and congenital hereditary endothelial dystrophy due to a degenerative and a dysfunctional endothelium. So the infant cornea is blessed with 5 lakh neural crest derived cells. The layer is 5 microns in thickness and 20 microns in diameter, and the surface area is 250 microns. It is typically 6-sided hexagon, where we can draw an analogy to the nature's honeycomb, because the hexagon is the most energy efficient and optimal shape to cover a surface without leaving gaps. So what happens to the endothelium from infancy to adulthood? At birth, it is 5,000, the cell density is 5,000 cells per millimeter square, and over the years, and by 5 years, it is 3,500, a significant reduction, and into adulthood, the number of cells is 2,500 per millimeter square, and there's a 0.6% decrease per year, and reaches the adult size by 2 years with an average horizontal diameter of 11.7 millimeters and a surface area of 138 millimeters square. And Descemet's membrane grows till death, increasing in thickness by 6 to 11 microns from 4 microns at birth, because this is actually a secretion of collagen from the endothelial cells. So this is the timeline. If at birth, the density of cells is 3,000 to 4,000 with a minimal surface area, it reduces to 2,500 to second to 8th decade, and in late adulthood, it reduces to less than 2,000, and an increase in the surface area of the cell and the layer of the cells becoming more flatter and flatter. Though the number of cells reduces, the corneal clarity is still maintained. While limited regeneration of endothelium, it is because of in vivo mitotic quiescence due to cell contact inhibition, expression of P27, arrest in the G1 phase of cell cycle, which is the most important aspect, which also plays an application in the recent advances of corneal endothelial cell regeneration, and expression of high TGF-beta2 in the aqueous, and lack of injury-inducible cytokine stimulating pathways. So when we compare the endothelial cell density in different populations across the world, the density is relatively lesser in the Indian population, and it is more in the Japanese population. So when we look at the ultrastructure of the endothelium, the scanning electron micrograph shows the hexagonal sites with a central nucleus and an extracellular matrix. And this is the transmission electron micrograph with an with a posterior stroma, anterior banded Descemet's membrane, and a posterior non-banded Descemet's membrane with an endothelium and an extracellular matrix. So, and there are various ways of imaging these are the various ways of looking at the ultrastructure of the endothelial cells. So after having described the disorder, the embryological origin of the endothelium and its disorders, one anomaly which requires a special mention is Peters anomaly, described by Dr. Alfred Peter, a German ophthalmologist, which is a rare disorder, but most common cause of congenital corneal opacity. So this is due to defective neural crest migration, and there is a defect in the central cornea posterior excavation, and based on the defect and other additions, it is classified into 2 types basically. Type 1 is posterior corneal excavation, and type 2 is posterior corneal excavation with the keratolenticular adhesions. And there can be reduplication of the Descemet's membrane and an anomalous Descemet's membrane matrix, which can be placed in the posterior corneal defect. And Peters plus syndrome is presence of Peters anomaly along with systemic features like cleft lip and cleft palate. So this is the AIOS picture. And this is represented in the histologic sections also, where there is a posterior corneal defect and there is an absence of the Bowman's membrane, a hypoplastic stroma, and the fibers are disorganized, and there is duplication of this splitting of the Descemet's membrane and the endothelium here because of the anomalous cells present. So based on the observation that the central corneal, due to a defect in the central corneal endothelial cells, if those cells are not defective, even the peripheral corneal endothelial cells compensate for the central defect. Dr. Muralidhar Ramappa et al. Have adopted a new technique of selective endothelialectomy in Peters anomaly, wherein the central corneal defect is aspirated and any adhesions are released. So this technique helps in the removal of the anomalous central Descemet's membrane and helps in the peripheral, and these peripheral cells migrate or compensate for the central defect. So these are most useful in the zone 1 Peters anomaly. But whereas in severe Peters anomaly with keratolenticular adhesions, these might not be very successful. So, but these are the few innovations in the surgical management of corneal opacities, wherein that there is the need for endothelial keratoplasty or a penetrating keratoplasty is avoided. So a knowledge of embryology and its application is important. So coming to the structure and functions of endothelium, a very metabolically active structure. The two most important organelles which are important in endothelium are the mitochondria and the endoplasmic reticulum. Mitochondria, due to the presence of mitochondria, it is metabolically active in the presence of sodium-potassium ATPase pump, and the presence of endoplasmic reticulum makes it more secretory by secreting the collagen and which is deposited as Descemet's membrane. So what are the functions of endothelium? It is basically detergescence, that is nothing but a state of relative dehydration and maintaining the corneal clarity. Any discussion on the corneal endothelium would remain incomplete without acknowledging the contributions of Dr. David Morris, who invented the specular microscopy to image the endothelial cells, described a mathematical model that became the basis for endothelial cell permeability, principles of fluorometry, invented the corneal pachymeter, and described the barrier and pump mechanism, which is very important in maintaining the corneal clarity. So how does the normal endothelium function? So what are the factors that are there in the endothelium for its normal function? So there are increased peripheral endothelial cells to maintain the normal density. There are tight junctions, and there are metabolic pumps at the basolateral membranes, and there is minimal apoptosis of the cells. So what are the steady state forces which keep the cornea clear? There are various factors ranging from the epithelium stroma and the endothelium. There is an epithelial barrier here and the stromal swelling pressure. The most important is the endothelial pump and the endothelial barrier mechanisms coordinated with the intraocular pressure. So what is this pump and barrier mechanisms? Barrier mechanisms are nothing but the tight junctions which are present in between the endothelial cells. Any defect in the tight junctions causes leak. And the pump is nothing but a metabolic pumps in the form of sodium potassium ATPase and bicarbonate pumps, which are helpful in the efflux and influx of ions and water across the endothelial cells and the aqueous humor. So this barrier function is determined by the number of the endothelial cells and the integrity of the tight junction. And what is this pump mechanism? This is due to the pump which is present across the basolateral membranes. The most important pump is the bicarbonate pump. So how are these bicarbonate ions produced? With the carbon dioxide combines with water with the help of carbonic anhydrase, and the bicarbonate ions are formed, which efflux into the aqueous humor. So along with the efflux of the ions, the water is also effluxed by thereby maintaining the stromal dehydration at a percentage of 78% of water. And the most important pump is a sodium potassium ATPase pump, which this sodium potassium ATPase pump works by transmitting the sodium ions across the cells, and this potassium ions is important in maintaining the resting membrane potential. So what happens if there is an imbalance? If the leak rate, that is the barrier function, is equal to the metabolic pump rate, the stroma is in a relatively dehydrated state, that is at 78% of water, and maintains the corneal thickness. If there are factors which affect the barrier function, causing the leak of the endothelium. So it is mechanical or chemical damage, disease states, calcium-free solutions, oxidation of intracellular glutathione, pH, and preservatives used in irrigating ocular solutions. So when the leak rate is more than the pump rate, the corneal thickness increases, thereby resulting in epithelial edema. So what are the factors that affect the pump function? Pump function is inhibited. Pump is basically the sodium potassium ATPase pump and the bicarbonate. Any drugs like obain and digoxin, which inhibit the sodium potassium pump, decreased temperature in the aqueous humor, lack of bicarbonate or carbonic anhydrase inhibition, and low function of the pump capacity as in disease states, keratoplasty, and decreased number of cells affect the pump function. So what happens in a compromised endothelium? So low calcium irrigating solutions, any solution with a pH less than 6.8 or more than 8.2, solutions with low osmolality, ultrasonic detergents, low endothelial cell density, endotoxins, exotoxins, and disease states like fugues, all these put together, or in separate entities cause stromal edema due to a compromised endothelium. So when does the endothelium actually decompensate? From birth till death, there is a 50% reduction of cells, but still the cornea doesn't decompensate because for it to decompensate, there should be a 80% reduction from late adulthood. It decompensates at a density of less than 500 cells per millimeter square. So there's an interesting observation by Armitage et al., who did a bi-exponential decay model on the rate of decrease of endothelial cells and found that and observed that normal corneal endothelium should maintain clarity for 224 to 227 years. So after having discussed the structure and the function of the endothelium, it is imperative to clinically identify the endothelium either by slit lamp examination or by specular microscopy. So specular reflection and specular microscopy are two important modalities in the clinical setup. So specular reflection and indirect reflection, which is a very fascinating type of reflection in indirect slit lamp illumination. The principle being the angle of incidence is equal to the angle of reflection. There should be a flat surface here. The flat surface is the interface of the endothelium and the aqueous humor. So the slit lamp settings for specular reflection is a narrow to moderate beam width, high illumination, angle of illumination, that is the angle between the observer piece and the illumination piece should be 50 to 60 degrees. Normally it is 15 to 30 degrees. And the magnification of a minimum of 25x is desirable, but if you have a 40x magnification, the delineation of the endothelial cells is more clear. And remember that it is a monoocular technique. So this is a short video on how the endothelium looks on specular reflection. So once we look at this mirror image, that is the reflection of the bulb filament, the area just next to the bulb filament is the area of interest. So this is the area where we have to look for the endothelium. It is a sheer joy if you just look at the endothelium for the first time. So it took really 3 years when our professor told that you have to look at this endothelium. Then it requires a lot of practice and some amount of dedication to look at this endothelium. If you keep routinely looking at it, then you'll be definitely able to see it. So this is the area where you can see the enlarged cells, and the hexagonality of the cells is also lost in this particular case. So the next diagnostic tool, the most important one, is the specular microscopy, where you're not able to clearly make out whether the endothelial dysfunction is present or not, is the imaging of the corneal endothelium. This is nothing but the principle is the same as the specular reflection. The only difference is the reflected rays are captured in a monitor. So this can be used in an eye bank or a clinical setup. So this is a typical report of a specular microscope. On the left-hand side is the frame of the cells which are being analyzed. On the right-hand side is the profile picture. And these are the indices which are measured on specular microscope. The number being analyzed here is 127 cells, the cell density, the average area in microns, the standard deviation, the coefficient of variation, the maximum and the minimum surface area, the central corneal thickness, the polymegathism and the percentage of polymegathism and pleomorphism. On the right-hand side is actually the frame of the cells that you see. In this, you can see there is loss of hexagonality. There are some triangular, pentagonal cells, and the size of the cells is also increased. So what are the indices? The cell area and cell density, which is calculated as 10⁻⁶ divided by average cell area. Polymegathism and coefficient of variation is increase in the variability of the cell area, which is the most important and a sensitive indicator of endothelial dysfunction. It should be less than 40. And coefficient of variation is measured as a ratio of standard deviation of cell area and mean cell area in micrometer square. So, and what is pleomorphism? It is deviation from the hexagonality. So when we look at the charts of the specular microscope of a normal endothelium, both the charts are of a normal endothelium. The left-handed side is of a 12-year-old boy, and on the right-hand side is of a 40-year-old person. So in a 12-year-old person, the density is definitely higher, and the cells of the sizes are small. And in a 40-year-old, the density decreases and the average cell area increases. So what is abnormal endothelium? So when do we suspect abnormal endothelium? So we need not have to look for specular reflection and exactly see the endothelial cells whether are functioning or not. An indirect evidence of stromal edema like this in a case of disciform keratitis or herpetic endothelitis, where there is stromal edema and there is, in this picture, if we magnify and see, we can see pseudoguttae. And the next most common scenario is the Descemet's membrane detachment seen post-cataract surgery and a very significant striate keratopathy indicating a lot of surgical trauma. And beaten metal appearance in Fuchs endothelial dystrophy. These are certain indirect signs to say that the endothelium is not functional. So the most common the most common primary cause of bullous keratopathy is Fuchs corneal endothelial dystrophy. It is a progressive hereditary disease of the cornea characterized by slow deterioration of endothelial cells and development of guttae. And the conventional modes of treatment are penetrating keratoplasty or endothelial keratoplasty. And there is an alternative method which is developed based on the same principle where the central cornea, even if it is decompensated, the peripheral corneal cells will compensate. Based on that knowledge, this Descemet rhexis without endothelial keratoplasty is being tried. And for this, for the peripheral corneal endothelium has to be healthy with a minimum cell density of 1000 cells per millimeter square. So what happens in Fuchs dystrophy? So this is an early stage of Fuchs where the cell density is still maintained. The guttae are there, but they are non-confluent. Here, the guttae are increased in number, but they are still non-confluent. Corneal clarity is still maintained. And in the cell density where it is 600 plus, there is a mild mild corneal haze. When we see the specular chart, it is very indiscrete. There is no differentiation, and you can see the percentage of polymegathism here. So, and in this, when we look at guttae, we have to differentiate it from pseudoguttae, which are seen in cases of anterior uveitis. These are nothing but dark areas on the endothelium. These are very transient, and they might disappear after the enticing agent is removed. So another congenital or developmental dystrophy is the PPCD, posterior polymorphous corneal dystrophy, characterized by presence of vesicles or bands, seen better on retroillumination. And the endothelial cells are conspicuously absent in the area of vesicles or glands. And this is when compared to the normal endothelium. ICE syndrome, unlike before discussing ICE syndrome, there's one more entity, there's congenital hereditary endothelial dystrophy, where the endothelium is not exactly visualized, but it is actually the corneal haze due to dysfunctional and degenerative endothelium. So the ICE syndrome, unlike the previous entities, it is not hereditary, usually unilateral, occurring in middle-aged women, and the endothelial cell density is less, and there usually is a clear demarcation between the ICE cells and the normal cells. These ICE cells usually form a membrane which crosses across the angle, which is responsible for the glaucoma and amblyopia. So what happens to the endothelium after PK? So this is a case of a patient who has undergone therapeutic PK. Unlike the 0.6% decrease per year of endothelial cells in normal individuals, the rate of decrease of endothelial cells after PK or any cataract surgery is more. After PK, it is suggested that it is 7 to 8% for the first 3 to 5 years. So it's a significant decrease. So at 1200 cells, it is still maintaining the corneal clarity when compared to the normal eye of the same patient. So after DSEG, Even the cells are, this is after DSEC. The cornea is clear here with the endothelial cell count of 1600. And the below picture is also after DSEC, but the count is slightly lesser and it is an impending graft failure. So the cells are bigger here. There is polymegathism, pleomorphism, which is very evident. The next entity is bullous keratopathy, nothing but the corneal edema due to various reasons. It can be due to primary reasons like Fuchs dystrophy, PPCD, CHED, or ICE, and acquired diseases like refractory glaucoma, herpetic endothelitis, previous failed corneal grafts, or surgical trauma most commonly. So pseudophakic bullous keratopathy or postoperative corneal edema is characterized by epithelial and subepithelial bullae, stromal edema, and endothelial decompensation secondary to trauma inflicted during cataract surgery. As you see in this picture, it is an anterior chamber IOL causing a localized corneal decompensation. Though the vision of the patient is fairly okay, he is happy with it, the symptoms are due to endothelial decompensation causing bullae and persistent watering. So what is the effect of IOP on endothelium? It depends on whether the endothelium is normally functioning, marginally functioning, or poorly functioning. If the endothelium is normally functioning and there is high IOP, it compresses the stroma. A classical clinical scenario is a clear and compact graft on postoperative day 1 after PK. Marginally functioning endothelium with a high IOP causes epithelial edema as seen in acute angle closure glaucoma, and poor endothelial function and high IOP causes stromal and epithelial edema post-cataract surgery. And low IOP causes thick stroma with no epithelial edema as in post-cataract surgery or trabeculectomy. And the next thing, what happens to the endothelium in contact lens wear? It is basically the insult to the endothelium is because of contact lens induced hypoxia. So not seen in all contact lens wearers, but due to various factors like low decay lenses, the design of the lens, the hours of wear of the lens, the type of the lens, whether it is daily wear or extended wear. So various morphological features are described as in transient or long-term. These transient changes are nothing, or blebs, which are nothing but endothelial cell swelling, which are seen just 30 to 45 minutes of application of a soft contact lens. And these are transient and reversible. Even once you remove the lens, these changes are reversible. In long-term changes, you can see clearly the pleomorphism and the polymegathism usually seen in extended wear contact lenses. So what is the effect of drugs? So the most commonly talked about drug is carbonic anhydrase inhibitors. There is no effect with acute administration, but a poorly functioning cornea decompensates after the administration of dorzolamide. There are various other drugs which can affect the endothelium. Amantadine, an NMDA antagonist and anti-Parkinson drug, can cause bilateral corneal edema. Methylphenidate and ropinirole dopaminergic agonists can also cause corneal edema due to endothelial dysfunction. Amiodarone, known to cause vortex keratopathy, can also cause endothelial dysfunction. Digoxin, by inhibiting the sodium-potassium ATPase pump. Zoledronate, which is used in osteoporosis, can cause severe ocular inflammation and endothelial dysfunction. And an inadvertent use of 1% methylene blue instead of trypan blue can cause a permanent damage to the endothelium, and obviously benzalkonium chloride. And this is a specular microscopy picture of a patient on amantadine, an anti-Parkinson drug, presenting with bilateral corneal edema with a very low endothelial count and a decompensated cornea. So what should be the ideal chemical composition of irrigating ocular solution for maintenance of this endothelial barrier and pump function? The minimum pH should be, the pH range should, most of all the things, the most important thing is the pH and the osmolality. The pH should be between 7.2 to 7.4 and the osmolality of 305 millimoles per liter. The next entity is toxic anterior segment syndrome, the term coined by Monson et al. In 1992. It is an acute sterile postoperative anterior segment inflammation following any anterior segment surgery, by definition sterile or non-infectious. What are the causes? Irrigating balanced salt solutions which do not comply with the pH and with the said pH and osmolality values, and preservatives used in intracameral antibiotics or anesthetics. If a residue of viscoelastic substances after cataract surgery, enzymes or detergents used in instrument cleaning, bacterial biofilm contamination of the autoclave, ETO sterilization, various types of IOLs which have reported to cause TARS, and most of the times the etiology is unknown. What are the clinical features of TARS? It is basically the onset of severe acute inflammation within 12 to 24 hours after any anterior segment surgery. presence of corneal epithelial and stromal edema with hypopyon and severe conjunctival hyperemia. And with proper diagnosis and treatment, it will resolve with these are resolving keratic precipitates in a resolving TARS. This can be still managed, but if it is managed, if it's not managed well, it can cause permanent endothelial dysfunction, necessitating for a corneal transplant at a later stage. So what are the morphological changes of endothelium in TARS? Lower endothelial cell density, higher mean cell area, lower percentage of hexagonal cells. How is the donor corneal endothelium in various preservative media? Optisol, GS, and cortisol media were found to preserve endothelial cell density better and stabilize the corneal thickness earlier as compared to MK medium. So after discussing about the embryology structure and the function, this dynamic layer of endothelium has advanced in many ways. So a few of which are corneal regeneration. The cell therapy focuses, this is required because of the limited availability of the donor tissue and the technicalities in the surgical procedures. Though there are many surgical innovations involving the endothelium, this is one area where the research is progressing very fast. Cell therapy focuses on the culture of corneal endothelial cells retrieved from the donor in the donor's cornea, followed by transplantation into the recipient. So these cells possess the ability to undergo mitosis in culture using these methods, and they overcome the G1 phase and complete the cell cycle. So they are able to do so by obtaining similar number of cells when specific growth factors are used. So the cells from both the central and peripheral areas of the cornea proliferate in vitro, and then they can be cultured from young and adult donors, obtaining similar number of cells when specific growth factors are used. So the other thing which I want to just mention here is the Rho kinase inhibitors. What does this Rho kinase inhibitor do for the endothelium? It inhibits the actin contraction, increases the focal adhesion complexes, prevents the membrane blebbing, prevents the loss of adhesion, and prevent the apoptosis of the endothelial cells. Though there are multiple, there's a lot of literature regarding the use of Rho kinase inhibitors in the corneal endothelial dysfunction, large-scale clinical studies are required to propagate its use in regular clinical use. So there are other recent advances like circular RNAs, like endogenous non-coding RNAs that regulate gene expression through the competitive endogenous RNA mechanism. These circRNAs are significantly dysregulated in human corneal endothelial cells in oxidative stress. So these circular RNAs can be used as markers for endothelial dysfunction. So gene therapy, is there any role? Yes, in the form of two genes, that is antisense oligonucleotides and CRISPR, which is nothing but cluster regularly interspersed palindromic repeats. And can we ever manufacture an endothelium which is close to the nature's gift? There are efforts towards it. EndoArt is a flexible silicon sheet covered with an adhesive substance that is inserted into the AC and attached to the posterior surface of the cornea by air or gas pneumopexy, similar to a DMEC graft. The silicon sheet prevents the passive influx of electrolytes and water into the cornea while allowing water evaporation from the corneal surface. Since this is a relatively new concept and device, there are no relevant peer-reviewed studies yet. So I would like to conclude my talk with this slide, where the progress of keratoplasty has been from a square-shaped penetrating keratoplasty to a DMEC graft. On the right-hand top side, you see an injury which has occurred to the endothelium by holding the graft in the with the help of a forceps. So from full thickness grafts to DMEC grafts, and also in the imaging of the endothelium, like specular microscopy, which was initially used to ultrastructural study of the endothelial cells. Thank you for your patient here listening. Thank you.
Thank you, Dr. Shweta, for a very excellent and exhaustive talk on such a small structure. You've given us a great insight into the endothelium. And I request the panelists to put in any comments if they have.
Beautiful talk, Dr. Shweta, very excellent. At this Kerakon, I had the opportunity to hear Dr. Kinoshita on what you said was the cultured endothelial cells, and he showed a few cases where they had injected the cultured endothelial cells after just stripping off a little bit of the desmase in the center. and even without that, and injecting rho kinase inhibitor into the AC, and they've shown excellent results. So if we can get the cultured, and the Japanese are making rapid progress in that direction. And like you said, the endocerta, that is the culture, the artificial endothelial cell layer is also being trying to be developed. But these are exciting times. And the tissue, that if we don't have enough tissues for D-sex and D-mex and such, probably the cultured endothelial cells would be the way to go. And rho kinase, one word about rho kinase inhibitors, I have found, I've been using it for about 5-6 years so far, and have done serial endothelial studies, that is specular studies. You find that the peripheral endothelial cells are normally more than the central cells in the normal case also. And if you have, and I have found an increase in the peripheral endothelial cells with the rho kinase inhibitor, no changing in the central, but the peripheral endothelial cells over a period of time has increased. But the limiting factor is they cause a lot of redness. And earlier only Glanatec was available. Now Ripatec and different kinds of Ripasudil and Netarsudil are available. Ripasudil preferable, because Netarsudil causes a lot of epithelial edema. So
Thank you.
Yes, ma'am. Thank you.
So just one or two questions. What is the role of anterior stromal puncture in corneal edema? Or is there any role as of now?
Yes, definitely. In cases of pseudophakic bullous keratopathy, where especially if the corneal decompensation is somewhere localized and the patient is not willing for any sort of corneal transplantation, just want a symptomatic relief from the pain and the blur, watering, all these symptoms, there is definitely a role for anterostromal puncture.
Okay.
Still keep
No.
doing it.
All right. And what is the technique of mini DEMEC for corneal hydrops in keratoconus? So people are now trying to, do a very localized transplantation of the endothelium. So is that established surgical procedure?
Mini DEMEC, I'm not aware of it, but definitely a selective endothelial cell removal which are defective will definitely help in the compensation of the lost endothelial cells. That is the basis for both the Descemet stripping only and also for SEPA, that is selective endotheliectomy. Definitely, whatever the defective cells you remove, the surrounding cells will definitely compensate for it. That is actually to avoid any transplant. So these techniques are developed just to avoid any transplant, the availability of the donor cells, basically because the most common cause of rejection is endothelial rejection. Just to avoid a transplant, these techniques are developed.
And there's one more question. Is there a role of collagen cross-linkage in treatment of corneal edema?
Yeah, there are reports of using corneal collagen cross-linking in cases of corneal edema. That is basically to promote scarring of the cornea, thereby reducing the symptoms of bullous keratopathy because there are bullae here. But most commonly, it is the anterior stromal puncture which serves the purpose.
Thank you. So I see that we have no more questions. Any other comments by the other experts on the panel? Otherwise, we'll move on to the next talk.
Yeah, so the practical exam or the practical viva of the PG students, they should be able to interpret the grading of the specular microscope, both the clinical specular as well as the Conan specular microscope. So that is important about that they should know about the hexagonality index, the coefficient of variation, the maximum cell density, the grid placement, and how to count. So that is the practical importance of corneal endothelial evaluation for PG students. I think Madam has covered it very nicely.
Okay, thank you. So our next speaker is Dr. Dasari Gayatri, who's a cornea and cataract surgeon, currently serving as an assistant professor at the Geetam Institute of Medical Sciences and Research, Visakhapatnam. An alumnus of the Andhra Medical College, Visakhapatnam, she went on to do a fellowship in cornea at Sankar Foundation Eye Hospital and Institute of Ophthalmology, Visakhapatnam. As a faculty, she is actively involved in mentoring and teaching and has published and presented her research work at various national and international fora. So over to you, Dr. Gayatri.
Good morning, everyone. Thank you, Guru Sangam, for giving me this opportunity. And today my topic is dry eye disease. It's not moving. Yeah, there's no financial disclosure. Coming to the definition of a dry eye. Dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by the ocular symptoms in which the tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play the etiological roles. So the prevalence of dry eye disease is influenced by the geographic location, climatic conditions, and lifestyle of the people. In India, the prevalence ranges from 5 to 35%. Coming to the risk factors, usually women in postmenopausal age, elderly age, low humidity, and more digital use like computer, laptops, tablets, smoking, and contact lens. Coming to a lacrimal functional unit, it is an integrated system that comprises the ocular surface, cornea, conjunctiva, accessory lacrimal and meibomian glands, the main lacrimal glands, the blink mechanism that spreads the tears, and the sensory and the motor nerves. Aqueous tear production by the lacrimal gland is largely due to a reflex initiated by the subconscious stimulation of the ocular surface and nasal mucosa. This stimulation initiates a sensory afferent signal from conjunctiva and cornea that travels via the trigeminal nerve to the central nervous system in the superior salivary nucleus in the pons. And from there, the efferent parasympathetic fibers in the facial nerve pass in the nervous intermedius to the pterygopalatine ganglion. Here, the postganglionic parasympathetic fibers arise and terminate in the main and accessory lacrimal glands, conjunctival goblet cells, and meibomian glands, where they will secrete the tears in response to the efferent signal. Another neural pathway controls the blink reflex via the trigeminal afferents and the somatic efferent fibers of the 7th cranial nerve. Classically, the tear film was considered to have 3 major layers: mucus, aqueous, and lipid. The contemporary concept of the tear ocular surface structure is that of a metastable tear film consisting of an aqueous gel with a gradient of mucin content decreasing from the ocular surface to the undersurface of the outermost lipid layer. Coming to the pathophysiology of dry eye disease is a multifactorial disorder involving multiple interacting mechanisms. Dysfunction of any component by causing alterations in the volume, composition, distribution, and/or clearance of the tear film can lead to the ocular surface disease. Two mutually reinforcing global mechanisms are tear hyperosmolarity and tear film stability. Coming to the tear hyperosmolarity, it results from low aqueous flow, excess tear evaporation, activates the inflammatory cascade and release of the inflammatory mediators, which leads to the apoptosis of surface epithelial cells and secondary lacrimal dysfunction. Tear film instability can arise secondary to hyperosmolarity, or it can be an initiating event, as in case of meibomian gland dysfunction. This chronic inflammation will result in lacrimal gland insufficiency, reduced corneal sensation, and decreased reflex activity. This is the etiological classification of dry eye disease. The dry eye disease is divided into major subtypes based on etiology, that is the aqueous tear deficient dry eye and the evaporative dry eye. Coming to the aqueous deficient dry eye, it has 2 major subclasses: Sjogren syndrome dry eye and non-Sjogren syndrome dry eye. So Sjogren syndrome is an exochrinopathy in which the lacrimal glands and the salivary glands are targeted by an autoimmune process. And there is a strong gender predilection, with women representing 95% of the patients. and it can occur at all ages with the peak incidence in 4th and 5th decade. The lacrimal and the salivary glands are progressively infiltrated by the activated T cells, which cause the acinar and the ductular cell death and hyposecretion of the tears or saliva. This inflammatory activation within the glands leads to the expression of the autoantigens at the surface of the epithelial cells, which are Rho and La antigens, and the retention of tissue-specific CD4 and CD8 T cells. There are two forms of Jorgen's syndrome. Primary Jorgen's syndrome refers to cases where there is no other associated systemic connective tissue disease. And secondary Jorgen's syndrome consists of features of primary Jorgen's syndrome together with the autoimmune connective tissue diseases such as rheumatoid arthritis, SLE, polyarthritis nodosa, Wegener's granulomatosis. This is the revised international classification criteria for ocular manifestation of Jorgen's syndrome. The first and the second criteria are subjective criteria, which consists of oral symptoms and the ocular symptoms. 3, 4, 5, and 6 are the objective criteria, which is third one is consists of the ocular signs, and fourth one is the histopathology of the salivary gland biopsy, and fifth one is the salivary gland involvement, which is tested by parotidocyanography or salivary scintigraphy, and the last criteria is the autoantibodies against Rho and La antigens. So depending upon those criteria, we can diagnose primary Jorgen's syndrome and secondary Jorgen's syndrome. Primary Jorgen's syndrome, there should be at least presence of 4 out of the 6 criteria, or any presence of 3 objective criteria items. Whereas secondary Jorgen's syndrome, presence of subjective criteria and any 2 out of the objective criteria. Coming to the non-Jorgen's syndrome dry eye, there are different forms of non-Jorgen's syndrome dry eye. That is the primary lacrimal deficiency, secondary lacrimal gland deficiency, obstruction of the lacrimal gland duct, and reflex hyposecretion. Coming to the age-related dry eye, this is very commonly seen. The causes of age-related dry eye is age-related ductal pathology and decrease in androgen levels. Ductal pathology is characterized by periductal fibrosis, interacinar fibrosis, paraductal blood vessel loss, acinar cell atrophy, which causes the obstructive effect of the lacrimal gland. And decrease in androgen levels, usually in the postmenopausal woman, and it is usually aggravated if the women are taking the hormone replacement therapy, especially the estrogen. Next, coming to the congenital alaclemia, it is a rare cause and causing the dry eye in young patients. There may be absence of hypoplasia of the lacrimal gland or abnormalities in the innervation of the lacrimal gland. It is usually bilateral and associated with familial dysautonomia, that is the Relay-Day syndrome. Coming to the secondary lacrimal gland deficiencies, there may be lacrimal gland infiltrations, usually seen in sarcoidosis, lymphoma, hemochromatosis, amyloidosis, graft versus host disease, and systemic viral infections. Coming to the obstruction of the lacrimal gland ducts, which can occur in cicatrizing conjunctivitis or other lid deformities which influence the lid apposition, and other cicatrizing conjunctivitis such as trachoma, mucous membrane pemphigoid, erythema multiforme, Stevens-Johnson syndrome, chemical and thermal burns. And coming to the reflex hyposecretion, reflex sensory block will occur usually in diabetes mellitus and neurotrophic keratitis. And reflex motor block if there is any systemic drug use with anticholinergic effect. Coming to the evaporative dry eye, excess evaporation from the exposed ocular surface will cause increased tear hyperosmolarity. The intrinsic causes are the meibomian gland dysfunction, disorders of the lid aperture, low blink rate. The extrinsic causes are chronic ocular surface diseases and contact lens wear. Coming to the diagnosis of the dry eye, first and foremost is the history taking. The symptoms of the dry eye usually are foreign body sensation, burning, stinging, itching, dryness, heaviness of the lids. We should ask the patient if there is any exacerbation of the symptoms during specific activities or environmental conditions such as reading or watching television, air conditioners, low humidity places, And temporal patterns we have to inquire about. That is, the aqueous tear deficiency tends to worsen as the day progresses, whereas the meibomian gland disease experience worse symptoms in the morning. And we should ask if there is any symptomatic relief with the artificial tears, and validated symptom questionnaires are there, which are used for screening and assessing the treatment effects. And we have to inquire about the past ocular and medical history, and any history of dry mouth or dental or gum disease, especially in the Jordan syndrome. And physical examination, we have to evaluate the face and the eyelids for any signs of rosacea or floppy lids, and dynamics of the blinking and lid position, and malpositions of the lid such as entropion, ectropion, eversion of the lacrimal punctum. Slit lamp examination, we have to evaluate the anatomical structures such as lid margins. We have to see whether there is any meibomian gland dysfunction, any hyperemia, telangiectasia, eyelashes, any misdirection, malposition. In conjunctiva, any erythema, swelling, especially conjunctival calluses, the conjunctival folds between the ocular surface and the lid margin. And next is the cornea, any infiltrate, scars, pannus, vascularization, and tear films, any filaments, mucus, debris are present or not. Coming to the diagnostic tests, we have to assess in 4 categories: tear film stability, ocular surface health, tear film composition, and tear flow. Tear film stability, usually we assess by tear breakup time. We instill fluorescent dye in the conjunctival sac and ask the patient to blink, and measure the time between the last blink and the appearance of the first break in the precorneal fluorescent tear film. The cutoff time is 10 seconds, and the other alternative test is the non-invasive breakup time test. Coming to the ocular surface health, we can diagnose by dye staining. The stain which is commonly used is the fluorescent sodium dye, which can penetrate when the epithelial cells loosen or desquamate. It stains the cornea more than the conjunctiva. And the staining is graded by Oxford grading stain or the Kleck schema grading. Another stain is the rose Bengal stain, which is more sensitive for staining the conjunctiva, which stains the devitalized epithelial cells. And but it is not well tolerated, and there may be side effects of irritation and reflex tearing. And the grading scale is the Van Bisterworld scale. And alternative to rose Bengal stain is the Lismine green P. Coming to the tear film composition, the osmolarity we have to measure. It is usually elevated in the dry eye, and the normal tear film osmolarity is 270 to 315 milliosmoles per liter. Cutoff value for the dry eye is more than 316 milliosmoles per liter. And in tear proteins, we usually analyze for lysozymes and lactoferrin concentrations. Coming to the aqueous tear flow and the turnover test. Usually we do Schirmer's test, which is usually performed. Schirmer's 1 test, the filter paper is folded at the tip and kept in the lower conjunctival sac between the lateral 1/3 and the medial 2/3. And the patient is asked to close the eyes for 5 minutes. And after 5 minutes, we see the amount of wetting which is assessed. And Schirmer's 1 test measures the reflex tearing. And if it is less than 5, it is severe aqueous deficient dry eye. Schirmer's 2, the Schirmer's test is performed with nasal stimulation. And Schirmer's test with topical anesthesia, Jones has popularized this measurement for basal tear secretion. And another alternative for Schirmer's test is the phenol red thread test. Coming to the delayed tear clearance or turnover, we need tear turnover to remove the inflammatory cytokines and provide a fresh supply of the growth factors. So delayed clearance of tears will increase the tear cytokine concentration and contribute to the chronic inflammation. So it is usually done by the fluorescent clearance test, where 10 microliters drop of 0.5% fluorescent in the conjunctiva sac is instilled, and tear turnover rate is determined by the persistence of the fluorescent in the tears at a specific later time points. Last but not the least, the corneal sensations. It is usually reduced corneal sensation will reduce the afferent signal for the aqueous tear secretion and reduces the blink rate. It will even alter the growth and differentiation of the ocular surface epithelium. Technique, it is a very simple technique. Take a cotton swab, extend few strands and touch the cornea and the conjunctiva from temporally towards the center, and the patient's blink reflexes seen. Other non-invasive methods for assessing the tear film, tear meniscus height. It is usually done in the slit lamp, and 0.2 millimeters indicates dry eye, 0.5 in healthy eyes it is seen. Another method is the interferometry, which estimates the thickness of the tear film lipid layer. In blood investigations, if any Sjogren syndrome is suspected, we have to see for antibodies against Rho and La antigens, rheumatoid factor, ANA, ESR, and C-reactive protein. Coming to the management of the dry eye, first and foremost, mainstay of therapy is the lubricants for all grades of the dry eye. The action of the lubricants, it increases the tear film stability, reduces the ocular surface stress, dilutes the pro-inflammatory substances, reduces the tear osmolarity, and improves the contrast sensitivity and optical quality. They are available as tears or ointments and gel. Ideal lubricant is a hypotonic or isotonic buffer solution, which contains electrolyte surfactants, compatible solutes, example glycerin, and viscosity agents like carboxymethyl cellulose. Lipid containing artificial tears are recommended in the meibomian gland disease. Coming to the punctal occlusion, it is usually indicated in the severe aqueous deficiency dry eye, and commonly used are punctal and intracanalicular plugs. These are used for temporary means of occlusion, electrocautery or laser for permanent punctal occlusion. Punctal plugs are contraindicated in presence of the ocular surface inflammation. Once the ocular surface inflammation comes down and control, then we can go for punctal plugs. Complication of the punctal plugs are epiphora, plug extrusions, infections, pyogenic granuloma formation. A word about the punctal plug, it is of two types. Absorbable, which is made up of collagen or polymers, which last for 3 days to 6 months. Non-absorbable are permanent. Example, Freeman style punctal plug, which is made up of silicone or hydrophilic acrylate. Coming to the contact lenses, example, Boston scleral lenses with fluid-filled reservoir, they help to protect and hydrate the corneal surface, retain the tear film, and promote the ocular surface healing. Indicated in severe dry eye with severe epitheliopathy. Other options are moist chamber spectacles, which reduce the tear evaporation and increase the humidity around the eye. And tarsorrhaphy, if there is any exposure keratopathy or severe dry eye with severe epitheliopathy, persistent epithelial defects, or stromal ulceration, we have to go for tarsorrhaphy. And tear stimulation or secretagogues for severe aqueous deficient dry eye disease. Examples are pilocarpine and civilamine. Next, coming to the biological tear substitutes, examples are autologous serum tears, which are produced from the patient's serum only, which suppresses the apoptosis of the conjunctiva and the corneal epithelium, used in severe refractive dry eye disease. Another one is the salivary gland autotransplantation, which replaces the deficient mucin and aqueous tear film phase. 80% of the grafts survive. Complication is hypoosmolarity of the saliva can cause the microcystic corneal edema. And next is the anti-inflammatory therapy in dry eye disease. First is the cyclosporin A, which is a fungal derived peptide calcineurin inhibitor. It reduces the pro-inflammatory cytokines, activated lymphocytes in conjunctiva, conjunctival inflammatory and apoptotic markers, and increases the conjunctival goblet cell number. Coming to the corticosteroids, it has an immunosuppressive effect and useful to achieve quick response and control of the ocular surface inflammation and controls the exacerbations. Limitations are risk of infection, increased intraocular pressure, posterior subcapsular cataract, so it's not suitable for long-term use. Short-term topical corticosteroids for 4 weeks can improve the ocular surface inflammation. Commonly used are loteprednol 0.5% for 4 weeks. Tetracyclines, these are bacteriostatic antibiotics and also have an anti-inflammatory property and protease inhibitor properties. Usually advised in meibomian gland dysfunction and rosacea. Coming to the macrolides, azithromycin 1% ointment is used in meibomian gland dysfunctions. It also has an antibiotic effect and anti-inflammatory capacity. It reduces the bacterial colonization at the eyelid margins and normalizes the lipid composition of the meibomian gland secretions. And next is the essential fatty acids. Usually it is obtained through the dietary sources, fish oil, and they are responsible for the ocular surface homeostasis. So omega-3 fatty acids is commonly used. They block the pro-inflammatory eicosanoids and reduces the cytokines through the anti-inflammatory activity. Other measures, eyelid hygiene is advised in meibomian gland dysfunction. And because the amount of lipid released from the meibomian glands depends upon the temperature of the eyelid. And so the melting points of the lipids in MGD rises to 35 degrees. So hot compresses is advised. And topical vitamin retinol, few studies are there which suggest a possible role of vitamin A in reversing the conjunctival squamous metaplasia and keratinization in the severe dry eye disease. Mucolytics is usually advised when there is filamentary keratitis. It is reconstituted with the tear substitutes and advised for topical use. And this is the dry eye severity grading scheme. The dry eye is classified into level 1, level 2, level 3, and 4, depending upon the discomfort, severity, and frequency. Visual symptoms, conjunctival injection, conjunctival staining, corneal or tear signs, lid or meibomian gland assessment, tear breakup time, and Schirmer score. And depending upon these levels, the treatment guidelines are in level 1. We have to focus on education and counseling about the lifestyle modifications, environment management, elimination of any offending systemic medications, and preserve tear substitutes are given. In level 2, unpreserved tears, gels, and ointments are advised along with steroids, cyclosporin A, secretagogues, and nutritional supplements. In level 3, tetracyclines or autologous serum tears and punctal plugs are advised. Level 4, topical vitamin A, contact lenses, acetylcysteine, moisture goggles, and surgery is advised. Thank you. This I have prepared in view of postgraduates. Any comments?
Yeah, thank you, Dr. Gayatri. Thanks for that excellent talk. Well, dry eye is something that all of us encounter every day, and the management of which we all should be familiar with, including our PGs. And another point that you highlighted is that dry eye is not one big group of conditions, but there are different categories of dry eye, and all of them would require a different management approach. So with that, I request the panelists to kindly give their comments. So anyone, Dr. Bhavana, if you could please. Dr. Shweta, any comments or any questions?
Tinku, it's an excellent presentation. I would just like to ask Dr. Gayatri, what would be her algorithm of investigation? Not, I mean, her clinical examination and algorithm. What would she start with? Would she start with the breakup time, clearance test, then Schirmer's? Or what exactly, how does she go about examining a dry eye patient?
Excellent. Yeah, a very practical approach to see a patient in the clinic.
First, I like to go with the tear breakup time assessment, ma'am. Fluorescence strip with small non-preserved saline drop. First, I'll measure the tear breakup time and look for any staining of the ocular surface and conjunctival staining with lissamine B. Next, I'll dry off the excess tears in the conjunctival sac and then place the Schirmer's test and then do the Schirmer's test in both the eyes. First priority, even corneal sensation first I'll see before putting any paracrine.
That's a very nice approach. I think when you put a drop of fluorescent, take up breakup time, and then you put a Schirmer's, you get a fluorescence clearance test also. So when you see the Schirmer's is being diluted, then you know the tear turnover is good. If the Schirmer's strip is really orange in color, then you know the fluorescent turnover time is less and the FCT is delayed, then in such cases, I think we don't think of punctal plugging in that point in time when there is less of fluorescent turnover. Another point about punctal plugging, of course, it's an industry-driven thing that we use the costly collagen plugs. We have also used chromic catgut or normal catgut. That also lasts about 2 weeks or so. It's a cheaper way. You actually cut off a little bit of that catgut, 2 or 3 mm, and then put it in the punctum. If you cut it and then, I mean, if you put it and cut it flush, it comes out. But you can cut it and then put it inside the punctum. The other thing is, if a person needs permanent plugging, ideal to do a punctal cautery. I guess rather than putting the plug, later flushing it off and some such thing, he needs a permanent. The thing is, when you use a bipolar cautery, it opens up. So if you don't want to make a permanent, you can use bipolar. But if you want to make it permanent, then use an Elman cautery. Really put it, the unipolar, inside the punctum, and then it permanently closes. So we have a good collaboration with our plastic colleagues when we want to use their Elman cautery.
Thank you. So I just want to clarify, should a rose Bengal or a lissamine green staining be a part of the initial workup in every patient of dry eye that we encounter? Should we stain the conjunctiva as well?
Lissamine G is preferable, madam, for conjunctival staining.
Okay. There's another question by our PGs. What is the management of conjunctivocalysis? Do the lubricant drops work, or does the patient need a surgical approach? So that's a very common condition and patients are really unhappy. Nothing really seems to work. So
It also occurs due to underlying loosening of that tissues, no ma'am. So I don't think surgery is needed for conjunctivocalysis.
Only in very symptomatic patients, then you just remove that excess conjunctiva and you can put an AMG or leave it like that. But very rarely, I agree with Dr. Gayatri, very, very rarely. I haven't done any surgical management for conjunctivocalysis as such.
And what is the tear film substitute of choice in a patient of post-operative dry eye, post-cataract surgery dry eye? A practical question, which, what
depends,
would be?
How many weeks after cataract surgery also, ma'am? Because immediately they'll be on steroids also. So for that, we need not means post-cataract surgery. We can just go for normal preserved artificial tears. Maybe if it is any like aqueous deficient dry eye, we first have to see what is the cause, and depending on that, preserved or unpreserved tear drops we have to give.
Okay. And no, what is the role of polyvinyl? Do we give them polyvinyl alcohol or carboxymethyl cellulose?
Those are the viscosity agents, madam. So which increases the retention time of that tear substitutes on the ocular surface.
Okay. And another question is that which is the tear film substitute to prescribe in a contact lens wearer, which he can use over the contact lenses, which would be your preferred tear film substitute?
I prefer unpreserved tear drops without any preservatives.
You can also put normal CMC drops, which are not concentrated drops. It can be used and they are prescribed. HPMC or CMC can be put on contact lenses, whether it is RGP or normal contact lens. CMC or HPMC, but not the thick gel types. You wouldn't use sodium hyaluronate on it.
Okay, thank you.
So I would like to ask the eminent panelists here, like with sodium hyaluronate coming up, with every pharmaceutical company promoting the sodium hyaluronate, what are the real indications where you are using the sodium hyaluronate, madam? Bhavna ma'am or Uma ma'am can answer this.
Yeah, very, very good and relevant question. That's something that all of us are confused about.
It's only like Dr. Gayatri said, grade 1, anything goes. Like if you have to use up till 4 times, then CMC, HPMC, anything goes. Then if you want it to be in moderate or severe, you want it to remain for a little longer time, then in those situations, you have to use sodium hyaluronate. And also in cases of, I feel, in computer vision syndrome, where people are sitting 8 hours, 10 hours on the computer, then the sodium hyaluronate based drops, they really help, because these guys don't even have time to put the drops. So you put once or twice a day, it lasts for a pretty long time. So in those cases also, you can use the sodium hyaluronate based drops. But as having said all this, a lot of it is industry driven, and one has to, and every patient does not accept the same thing. A lot of time it is trial and error. But in the, of course, moderate to severe, and you want it to last for a longer time, you use those.
Another important thing that Dr. Gayatri highlighted was the use of, steroid drops in severe dry eyes. So do you think that should be in severe dry eyes, or how should you give steroid drops, and which steroid drops?
Ideally, soft steroids, FML, lotipred, when there is, when you see the fluorescence clearance time is delayed, that means the toxins are staying on in the surface for a long time. They're not getting flushed. There is a surface inflammation. Then for a short period of time, you do give steroids, FML or lotipred, or, I mean, the fluoromethalone, no industry thing, but soft steroids are given. But later on, you follow it up with cyclosporine or tacrolimus, which are steroid sparing for a longer time. This is for surface inflammation. Of course, dry eye, as the definition itself says, that's an inflammatory disorder of the ocular surface. So initially, when you see a delayed FCT, yes, you do give.
Mm-hmm. And any other question or any other comment by the panelists?
No, I'd like to add a comment on the incidence of dry eye in postmenopausal women. So they might not actually complain of dryness of the eyes. So it is basically some grittiness or discomfort. So it is imperative to check for dry eye in this postmenopausal women, which we might tend to miss. So, and regarding the use of corticosteroids, so it is for a short period, as Madam said, before cyclosporin takes action. So if we start both concurrently, the cyclosporin takes action in 1 or 2 weeks. So by the time this topical corticosteroids will act, but not routinely in all cases, more so in cases with systemic immunological diseases like rheumatoid arthritis and all, it is more useful.
And to all the panelists, what is the role of omega-3 fatty acids? Do they still have a role? Because there have been a lot of literature which is very conflicting. So in your practice, would you give a omega-3 fatty acids to a patient of dry eye, and to which class of patients?
Aqueous deficiency, definitely. You can also give an evaporative dry eye. Even the macuberry extracts, they do help. So they're not really anecdotal. There are a lot of studies. Yes, you do give it. And they are helpful. Yeah.
Dr. Shweta, what's your take on that? Omega-3 fatty acids orally?
Not certainly in all cases, maybe in severe dry eye, and there is some associated lid margin disease and something to do with the lipid secretion. Definitely we would give omega-3 fatty acids, but not very routinely.
Mm-hmm. So I don't see any more questions in the chat box. So I thank all the speakers. These talks have been excellent, very exhaustive, very detailed. And I thank all the speakers for their contribution. I also thank Dr. Harbans Lal, the president, for his presence here and for his constant encouragement. Dr. Santosh Honavar, who has been, fine-tuning this session all through. And I would thank all the audience, all the PGs who logged in. With this, we come to an end of this session. And we would have our next session on 7th December. We have a next session next week, next Sunday, from 10 a.m. onwards with 4 more lectures. So we would be seeing you then, and hope more people can log in and benefit from this.
Tinku, there is a cornea diagnostic or AIOS Prayogshala from 10 to 1 next week at the AIOS headquarters. If the Delhi NCR people can think. I think Dr. Santosh will come out with the flyers from tomorrow.
All right. So that's a very good pointer. So I request all the PGs to make the most of this opportunity. And again, I'm emphasizing that our next session is on the 17th of December, 10 a.m. onwards. So do log in for 4 very interesting lectures. And with that, I thank all the speakers, the audience, and hope to see you next week again. Thank you so much.
Thank you,
Thank you.
Tinku.
Thank you.